disease. So epicardial coronary artery spasm is frequently in patients, but microvascular disorder of the coronary artery is also to be met this patient. So this is the three mechanism. I think that and we also have two methods to predict the risk of atherosclerotic cardiovascular risk disease. Number one is a European guideline, and number two is a US guideline. I think that US guideline have advantage being simple and can be applied in variety of the field. So in this study, the patient was stratified according to 10-year atherosclerotic cardiovascular risk score in US guideline, and I investigated different instances of coronary artery spasm in stratified patients with chest pain without significant coronary artery stenosis. The study duration is from January 24 in December 2021. And number is the 7,059 patients who had no significant coronary artery disease, who underwent the acetylcholine or ergonovin provocation test. The standard classification showed that the atherosclerotic cardiovascular disease risk score is such like this, but I think that the low risk for less than 5% and borderline risk for less than 5% to 7.5%, and medium risk for the less 7.5% to 20%, and high risk for more than 20%. But I think that this classification method may underestimate the risk of patient in the borderline risk groups. So we needed more things. So as you know that the United States Prevention Service Task Force recommended that the 10% is very important, because the 40 or 50 years old patient who have a 10% or greater 10 years cardiovascular risk factor, they recommend the prescription of statin for the patients for primary prevention. So we add the 10% to a cutoff value in this study to meaningfully analyze the patient. So in this study, patients were classified 4 groups by score: 5%, and 5 to 10%, and 10%, and 20%, or more 20%. So this is the 4 groups. So the patient population is like this. This is the intracoronary acetylcholine purification test method. Like we perform the test like this. This is the testing method like this, and this is the result. The baseline characteristics show that the high-risk group, the score over 20%, have a highest portion of the male patients and older patients, and have a more hypertension, diabetes, dyslipidemia, and history of smoke. And the instance of a coronary spasm is highest in the high-risk score patients. And as you know that the coronary artery stenosis less than the 70%, this is the insignificant stenosis, is increased from low risk to high risk groups like this. And this is the prevalence of the coronary spasm according to the 10-year atherosclerotic risk score from like this. So the total instance is 56.5%, but from low risk to high risk group, the instance is increased like this. And this is the odor ratio of the risk of a coronary artery spasm according to 10 years scoring system. So as compared the low risk group, the borderline groups is odor ratio is 1.191, and intermediate group is odor ratio is 1.145, and high risk group is 1.429. So this increased from the low to high risk groups. So this is my summary. 10 years atherosclerotic risk score is very important, and we can patient stratified from like this. In high-risk group was older and had more hypertension, diabetes, dyslipidemia, and smoking history. They have the risk patient. And the overall instance of coronary spasm is 56.5%, and middle moderate coronary spasm, it is a non-significant stenosis, is 53.8%. So from low-risk groups to high-risk group, the instance of coronary spasm is gradually increased like this, and the rate of non-significant stenosis is also the increase like this. So, and also the odor ratio is increased from low-risk to high-risk groups. So I can conclude in this study, the patient stratified according to the US guideline, and we investigate the different instances of coronary spasm from low to high patients. And in this study, the 10-year atherosclerotic cardiovascular risk score can predict the incidence of spasm in ANOCA patients, and it also relates to the rate of intermediate coronary artery stenosis. So we think that the 10-year atherosclerotic cardiovascular risk score play a role to predict the instance of coronary spasm, and it is expected to help doctor decide on treatment for patients with ANOCA. Thank you for your attention. Thank you.
Thank you very much. A very provocative and interesting study, and I would say very much consistent with the model we have now for understanding ANOCA as a disease with many different triggers and many different explanations. This paper is open to the panel for any questions or discussion. Would the panel like to make any comments?
Thank you for your nice lectures. I think the increased rate of the coronary artery spasm is according to the increased atherosclerotic progression. So, is it enough just starting therapy is enough, or any other medication, for example, anti-angina medication or antiplatelet agent? What do you think about it?
Thank you for important comments. I think that the studying is very important for predict prevention this disease. But in my case, when the patient have significant chest pain with ANOCA, I prescribe the clopidogrel in this patient because when he have a significant spasm, at the time the unstable angina can be occurred. So in my case, I prescribed the antiplatelet agent in this patient. And also, as you know, that the vasodilating medication is also helpful for this patient to treat their chest pain. So I also prescribe the anti-angina drugs such as the diltiazem and licorandil and trimetazidine. So this is covered the insurance in Korea. So I also prescribe vasodilating drugs for this patient. Yeah.
Some question from here. As a bystander of your research process, I have several questions for you. Did you publish this article?
No.
No, not yet. Okay, I have some definition issue on your study. What you investigated the 10-year event. what was the definition of 10-year event? Death, MI, or hospitalization? What was there? And the second, I'm not sure. You must calculate the 10-year risk score on app or age guideline calculator, but up to my knowledge, that is for primary prevention. But your patient has clinical disease. So I'm not sure you can use that calculator.
Thank you for important comments. It is very important things for this paper. I think that we have a limitation for calculate the risk score in the for secondary prevention in this patient. So we just use the 10 years risk factor score, but I think that we try to investigate another risk score for secondary prevention in these patients. I think that this is the limitation in this study. And 10 years cutoff value is very important things in this paper, because when we try to the statistics, that we knew that 10% for cutoff value is important for stratifications in the patient. So we used the 10%, but we try to get a more reference in this the cutoff value. So we showed the US first recommend the stratification for using a statin in the patient for primary primary prevention, but in your comments, the secondary prevention and primary prevention is very different. So, yeah. So in the future, I try to the reference for this this topic. Thank you.
What was the 10-year event?
10-year event.
Yeah.
10-year event.
What was what was the
10-year
purpose
event.
of 10-year? You investigate.
10-year.
Yes.
Oh.
You actually investigate 10-year event.
10-year risk score I used. 10-year.
Just the risk score.
Yeah,
The
just
act-
the
not
risk
actual
score.
event. Okay.
Yeah, risk
Okay,
score.
okay,
Yeah,
okay.
so we can calculate this risk score for app. Yeah, so yeah. Thank you.
Very good. Thank you very much. Appreciate the presentation very much.
Okay, let's move to next speaker. Because of technical problem, we move to third speaker, Dr. Gulati from United States. I'm so glad to introduce Dr. Gulati here. His title is Dissection, Observation for New Mechanism of Disease. Please, Dr. Gulati.
Thank you. It is wonderful to be here back in Gwangju with my friends, Dr. Chung, Dr. Garrett, and my friends all back here on the panel. It really is great to be here. Thank you for the honor of presenting today. I will ask for my slides, please. Thank you.
Sorry about that.
Oh, well. Oh, well.
선생님, 두 번째 연장 강의 열어야 돼요. 아리나 뒤에 어디서 열면 될까요? 지금 잘 보고 있어요, 지금.
like we're good. We have it. Thank you. Perfect. Thank you so much. Thank you.
Thank you. After your speech, just read the internet.
Thank you. Good morning, everyone. Again, thank you. Thank you. We have a thing. So I'm going to ask people to look at the. Can you see? Can we see it on this screen here?
Can you use
I can. I think they can't see the screen here.
여기다가 화면을 이렇게 띄워.
Here we go. Thank you. All right, wonderful. Thank you. So this is, I'm going to show a series of cases and some observations from the cases and a new hypothesis for disease. And I really would appreciate your criticism and critique of the hypothesis. So here, look at this. Is this Takotsubo? Well, 20 years ago, we would have said this was an LAD occlusion that is recanalized, but we've learned that this is more possible. This could be Takotsubo, but it's hard to tell. How about this case over here? I think this is much more obviously a non-coronary event. This is mid-ventricular ballooning. The mid-anterior and mid-inferior walls are dyskinetic and hyperkinesis of the base and of the apex. So I think you would agree with me, this is less likely to be a coronary event. This is more likely to be a mid-ventricular stress-induced cardiomyopathy. So here's the same patient. There's a still of an LV angiogram on the left, and here's the same patient's coronary angiogram on the right. And the arrow here is pointing to a step down in caliber of the LAD. And if we do OCT of that area, we see a large eccentric intramural hematoma. So this is spontaneous coronary artery dissection. If you look further, there's an intimal dissection in this OM as well. So here, in this case, we have a combination of a mid-ventricular Takotsubo and multi-vessel spontaneous coronary artery dissection. So what is going on in this particular case? Well, I think there's only three explanations. The first is that the acute emotional stress caused two events. It caused a stress-induced cardiomyopathy, and maybe it caused the spontaneous dissection. Or is it that she had a transient coronary problem with the SCAD, and then the pain and distress caused a secondary stress-induced cardiomyopathy? What I'm trying to convince you of today is that it's none of those two, but it's this third pathway, that the stressor caused stress-induced cardiomyopathy, and the torsion forces from the myocardium caused spontaneous coronary artery dissection, or a mechanical stretch of the coronary arteries causing disruption. Now, every day in the cath lab, we see some variant of mechanical interaction with our vessels. Here, this is an axillary loop, and here you can see how the shoulder, the arm gets pulled to the side to straighten out the axillary artery to advance the wire across. But a common thing we do in the cath lab. We also know that the superficial femoral artery in the leg is very prone to atherosclerosis, and this may be because of the twisting torsion forces in the SFA and popliteal arteries. But perhaps the best proof of principle that mechanical forces can cause disease is in this case here, a 42-year-old female who went to have a haircut. Now, you know when you go to have a haircut, they wash your hair and they put your head back in the sink like this? Well, when she put her head back in the sink and then straightened it out, she developed an immediate headache and a left hemiparesis. And that is because she suffered bilateral internal carotid artery dissection with the stretched forces of the neck. We've seen this in golf, right? The turn of the head in golf. In the chiropractic, the neck manipulation can cause dissection of the carotid arteries. So we know this is proof of concept that mechanical hyperextension forces can cause tearing of the carotid arteries. The question is, can this cause disease in the coronary arteries, namely the hinge point here between the hyperkinetic and the dyskinetic segments, these junction of wall motion abnormalities, can they cause tearing of the vessels? Well, in this particular case, there was no late gadolinium enhancement, so no myocardial infarction. MRI was strained, that I'm not an MRI person, but the MRI experts tell us that the strain and strain rate, the points of maximal LV distortion, matched exactly with the sites of two-vessel coronary artery dissection. We see here maximal change, we see here and here. So in this one case, there is a suggestion that the hinge point in the left ventricular myocardium corresponded with the sites of two-vessel spontaneous dissection. So that's one observation from one case. How about we look at other observations that might support that Takotsubo caused coronary artery dissection? Well, here's another case, and you see a patient who has multi-vessel spontaneous dissection. Now, if we think about it, why should two vessels dissect immediately at once? If there's an endoluminal problem or a biochemical problem that's causing tear or weakness of the media or bleeding of the vasa vasorum, that shouldn't happen immediately in two vessels at the same time. And even more interestingly is how multi-vessel dissection can occur in regions. And look at this patient, the two vessels are both involving the apex, the LAD and the PDA. Could it be mechanical forces are causing this dissection? How about a more compelling example? This is a patient with multi-vessel dissection, and you see affecting three lateral wall branches, the ramus, the diagonal, and an OM, all dissected in a plane here. I'm going to play the LAO view of the same patient. We can almost draw a line, a hinge point line of where those dissections have happened. Not only in the left coronary artery, but if we look at the same patient in the right coronary artery, the posterolateral, two branches of this. So 5 lateral wall branches, all dissected in this one patient. To me, that is quite compelling that this is a mechanical cause and not an endoluminal or biochemical cause of dissection. Some more observations. Here are two patients, two IVUS. You can see here intramural hematoma. It looks very similar, but actually the cause is SCAD in this case and a blunt chest wall deceleration injury in this case, but they look pretty much identical. Two cases from the pathology lab. If you look at these cases, they look very similar. Intramural hematoma, there's loss of blood in the artifact of processing. Intramural hematoma causing compression of the coronary artery, compression of the coronary artery. But the cause was completely different. On the left, it's spontaneous dissection, and on the right, this is a deceleration injury of a woman who died in a fatal car accident, traumatic LAD disruption. And if we look even closer, we can see now we have 13 pathology studies as samples of spontaneous dissection. We see adventitial bleeding not communicating with medial bleeding. Could it be that the cause of this is trauma and not some intrinsic other process? So we believe this is a new hypothesis, and it should of course be subject to criticism and to other study to refute it. But other things start to make sense if we think about this construct, that the disease is all stress-induced cardiomyopathy causing distortion, and in vulnerable patients or vulnerable vessels getting spontaneous dissection. We call it AMCAD. If we think about spontaneous dissection and the phenotype of patient, the median age in registries is 50, it affects women, and it's caused by acute stressors. Think of that same patient description, but now say the median age is older, 67. That sounds like typical Takotsubo. So in all other respects, these women are the same, they're just different in ages. And it may be that the older patients have more resistant vessels that do not get disrupted or distorted. I will share with you that these are all clinical observations, and we have tried hard over the years with bench studies, with genetic studies, with proteomics, and we have not made much insight into mechanism with bench studies, but with clinical observations, we've had a more deeper understanding of what vulnerability there is in the vessel wall that predisposes someone to dissection. I've listed them here in the top box. And now we're thinking about, well, what could be the trigger? Could it be a mechanical cause? So this mechanical hypothesis, and I'll stress again, it is a hypothesis, that there is just one disease, and that disease is Takotsubo. And in the older patient, the coronary arteries are resistant, and it manifests as Takotsubo. In the younger patient with a vulnerable artery, the vessels get dissected with those torsion forces from Takotsubo. The questions remain, is this a true hypothesis? Does it apply to all spontaneous dissection or subsets? Or could it even be a trigger for other diseases like multi-vessel plaque rupture? I hope that's provocative. I want to thank my colleagues for your time and listening. I really appreciate the opportunity to be here in Gwangju once again. Thank you.
Excellent presentation, Dr. Galati. This is now open to comment or questions from the panel.
Thank you very much for nice presentation, Matsuo. I have a question about treatment of for the patient with
Put belly.
coronary artery obstruction caused by mechanic causes. So when we see the patient, so we usually consider about the treatment of the vessel. But if we encounter such a patient, we have to focus on the prevention of hyperkinetic wall motion? So do we have to use, for example, beta blocker or something? What's your thought?
I think it's a great question, and that logic makes a lot of sense, that if we're going to treat a mechanical force that we give beta blockers. But we also know that after Takotsubo, the recovery is quick anyway of the left ventricle. So it may be that by the time we get to see the patients, there's already some recovery of the myocardium. But the logical next step is if there's somebody, for example, who has a disproportionate left ventricular dysfunction like Takotsubo, with dissection, I think beta blockers make a lot of sense. We know from observational studies that the only medication that reduces the risk of recurrent spontaneous dissection is a beta blocker. So that would be consistent with your hypothesis that maybe we should be providing beta blockers to this patient population. These are new observations, but I think a logical next step will be to study this in a systematic fashion, maybe with IV beta blockers versus placebo in patients presenting with dissection. And we will think about doing that. Thank you, Yoshiki.
Any other question? So, do you like to say the SCAD has two kinds? Because I support your hypothesis, but however, we can explain the distal vessel SCAD with the stress condition, because there is no bending force. How do you explain the distal vessel, small vessel SCAD?
Yeah. It's a great question, and we don't know is a short answer. Are there multiple different mechanisms at play here? I don't think we can say with certainty that distal vessel is not caused by mechanical forces, because often we are making the diagnosis angiographically. We see distal vessel disruption, but it may be that there is actually disruption much more proximally because we're not routinely imaging all of these patients. And often when you see a distal SCAD, the vessel caliber is narrower much more proximally. So maybe even distal SCAD is beginning more proximally in the vessel. So I don't think we know that with certainty, but it may be there are different phenotypes of patient here. My suspicion is that pregnancy-induced or postpartum SCAD is a different process. Those patients present very differently. Multi-vessel SCAD to me is the most likely one to be a mechanical change, because otherwise why would multiple vessels dissect at once? The distal, I think, remains to be seen. It remains to be seen. Yeah.
Dr. Bulati, I have a question. I think that the SCAD is diagnosed by imaging modality, usually, we cannot see the dissection flap on angiogram. It is very feasible for the wiring and to the imaging modality. But we can see some dissection flap, then it is very difficult to advance the wire. So do you have any tips or other, give us tips for the advanced wiring or using imaging modality?
Yeah, no, it's a great question. I think when we look at diagnosis of SCAD now over the years, everybody has got much better at recognizing SCAD by angiogram. So most SCAD, I think, is diagnosed purely by diagnostic angiogram. If you see an intimal dissection flap, I don't think that needs imaging. I think you have your answer. But 75% of SCAD in the mid and proximal vessels is just intramural hematoma, no dissection flap. So the ones that I think need imaging are the ones where there's genuine ambiguity. You have a proximal or mid lesion, typically mid, without a dissection flap. I think that is ideal for imaging. And then HD-IVUS or OCT would be the two imaging choices. Because it's really crucial that we don't miss atherosclerosis. We've seen many cases where people have been thought it was SCAD, but actually it was atherosclerosis. And we have great treatments for atherosclerosis, right, stents. So it's very important that we image those proximal and mid vessels.
Question more? Okay, thank you. Just slowly move to the next speaker. The next speaker is Dr. Guerra from USA. His topic is new innovation to controlling hypertension. I'm so glad that he always the very interesting and unfamiliar topic with Korean doctors. I'm expecting so much this time as well.
Well, thank you very
Dr.
much.
Guerra,
It's-
please.
Thank you very much. And as with Dr. Galati, it's just a delight to be back here with good friends and always look forward to this conversation. I learned so much coming here from this group, and it's such a delight to be able to visit with you again. That's Dr. Bell. We will be doing Garrett. Top. Yeah, there. Yeah. Yeah. Mm-hmm. Okay. Presentation mode. Is that this presentation right here? Yeah. And next one? Oh, yeah, good. Terrific. Thank you very much. Thanks for your patience. Well, it's a delight to be back with you, and I'm going to make a few comments about hypertension. Now, this is an interventional symposium. Why would I be talking about hypertension? Well, I know things have changed a lot in Korea. They've certainly changed a lot in the United States in the past 20 years or so. Smoking rates have fallen quite precipitously. 20 years ago, 25 years ago, something like 23, 24% of Americans smoked. Now the number is more like 15%, and because smoking has such an outsized impact on the development of atherosclerosis, that's had a very, very positive impact. Diabetes has been rising quickly as Americans have been getting much heavier, but interestingly, although diabetes is clearly associated with atherosclerosis, it doesn't appear, at least thus far, that this epidemic in diabetes, type 2 diabetes, has been associated with quite the increase in rates of coronary events as we had initially feared. As a result, today, hypertension has surfaced as the #1 preventable contributor to atherosclerosis and cardiovascular events that we can modify. It's the most powerful driver of coronary atherosclerotic and other cardiac events that we know of today. So I'll spend a few minutes talking to you about what we're seeing in the U.S. in the way of new medical therapies, new devices that the interventional community will use to provide care. And then I'll touch on a new approach that we're using at Christiana Care that I think you might find interesting. Okay, let's go ahead here. No, that didn't do it. Here we go. So where are we with hypertension that's difficult to control? Interestingly, according to the World Health Organization, Korea actually does better than the global average. You have fewer patients bothered with difficult to manage hypertension than most nations. The United States, on the other hand, according to the World Health Organization, has a much higher percentage of patients who need additional care. Now, that's the World Health Organization. The United States Center for Disease Control actually estimates that our rate of poorly controlled serious hypertension is even higher yet, approaching 50% of the population. And by some estimates, Americans who reach the age of 50 and have normal blood pressure may have a risk of as high as 80% of developing hypertension before they die. So it is a very, very substantial problem in the United States. Is this still a problem worth spending time on in Korea? Well, I think so, even though your population management is much better here than in the United States. I still note that the World Health Organization notes that if the aspirational goal of achieving more than 70% control of this population is realized, then by the year 2040, you will have saved an additional 78,000 lives. So I think this is a topic still relevant in Korea. Why would that be? It's because we've learned that even modest changes in blood pressure, a reduction of 10 millimeters of mercury in your systolic blood pressure is associated with very substantial reductions in cardiac events, a greater than 20% reduction in all cardiovascular events, greater than 13% reduction in CV mortality. So this is worth paying attention to. I'm going to touch on a couple of new drugs that we're very excited about. The first is an oral agent, the second is an injectable. Let me talk first about aprocitentan. Aprocitentan is a new endothelin antagonist. I remember when the initial article came out, I was a fellow at Mayo Clinic, and this spectacular article was published in the New England Journal describing this new compound endothelin. And endothelin, it turns out, as we know now, has a very important role in vasomotor tone. It's been used as an injectable compound for pulmonary hypertension for quite some time. We now have a compound that is an oral agent that will interfere with the function of endothelin-1 on two of the key endothelin receptors, receptor A and receptor B. As you can see in this cartoon, receptor A and receptor B are both involved in vasoconstriction at the smooth muscle cell level. Activation of endothelin B receptor also triggers a counter-regulatory release of nitric oxide from endothelin in order to maintain balance. But the overall effect of endothelin release in this environment is one of vasoconstriction. In addition, activation of the endothelin B receptor at the renal level is very much tied into fluid retention, sodium retention, and increasing blood volume. So interfering with the endothelin A and B receptors would be expected to have an important impact on blood pressure. And in fact, in preliminary trials, that was observed. Recently, we have seen completed a large-scale international multi-center randomized trial of this oral agent in patients with hypertension. And in this blinded phase 3 study, you can see the two different doses of this compound, aprocitentan. These doses were associated with a dose-responsive improvement in blood pressure that was meaningful. That is, reductions in the roughly 8 to 10 millimeter of mercury range, enough that we would say we would expect those reductions, if sustained, would have a positive effect on cardiovascular event rates. Because of this study, this compound was approved by the United States Food and Drug Administration just a couple of months ago and will be available commercially soon in the United States. I am unsure if this drug is going to be available soon in Korea, but I would certainly hope that it would be. Importantly, there were Asian centers involved in this randomized trial. I'm going to turn my attention now to a different drug, a class of drugs that I find personally incredibly interesting and very exciting. And these are the small interfering RNA compounds. I don't know how many of you have had time to study these, but this is a really interesting idea. We know we can synthesize RNA compounds, and we can synthesize them in a manner that we know a specific sequence is contained in a long strand of RNA. We then have catalytic enzymes that will cleave out sections of RNA code that are of interest. If you do that, you can then attach that ribonuclide onto certain proteins. This is really a key step. By attaching the RNA molecule to a protein, you can do two things. The first thing you can do is create a protein aggregate that is recognized by a cell surface receptor, and that will allow the compound to be absorbed into the cell. Secondly, you can attach catalytic enzymes to this ribonucleic acid that will have functions inside the cell that you wish to achieve. In this manner, proteins are attached to the ribonucleic acid in single-strand form. That compound forms then what we refer to as an RNA-induced silencing complex. This complex is absorbed into the cell. It binds then messenger RNA that's coding for a specific protein, and the catalytic enzyme cleaves that messenger RNA, silencing it. The net result is you stop production of that protein within that cell. This new compound zilebesiran, is a compound that is targeting angiotensinogen, the precursor molecule for angiotensin, at the hepatic level. This drug proved in phase 1 studies to be safe and associated with important reductions in angiotensinogen production. Then secondarily, the therapeutic effect was measured in a phase 1 trial that showed, as you can see here, meaningful reductions in systolic blood pressure in the 10 to 20 millimeter range at varying doses of the injectable. Now, importantly, this drug has been found to have sustained impact on blood pressure out to as much as 6 months after a single subcutaneous injection. So imagine now a single subcutaneous injection that will reduce systolic blood pressure by 10 millimeters of mercury, perhaps more, in a patient with refractory hypertension. The impact of that is very substantial. This drug has also been tested in combination with standard oral antihypertensive medications and found to provide additive impact, very important when we think about the potential of a drug like this for refractory hypertensive patients. This trial is now undergoing additional study. We're still in the phase 2 phase of work with this compound. It's currently under study in high-risk patients with refractory hypertension on stable doses of 2 to 4 medications. Primary endpoint in the ongoing trial is blood pressure change at 3 months, but we will be looking also to see the 6-month outcome data for this trial. Thus far, the safety information is all favorable. I anticipate that if this phase 2 study is a positive one, as hoped and expected, we would see quickly a phase 3 study to follow. This drug could then be commercially available in perhaps 24 months. Okay, I'm going to shift back now to the thing of real interest to this group, and that is interventional techniques. The idea of using catheter-based means to interfere with sympathetic nerve signaling from the kidneys to the brain is not new. This is an old idea. Just recently, 2 catheters, the Medtronic device and the Recor Health device, were approved for commercial use in the United States. It's my understanding that these devices are available in Korea and have been available for a bit. We're just going to talk a little bit about what is the promise and potential of these devices. Everyone remembers the Simplicity trials. A lot of excitement when Simplicity 1, as a proof of concept study, demonstrated that ablation of renal artery sympathetic nerve signaling could be associated with very substantial reduction in systolic blood pressures. Then in a randomized phase 2 trial, again, very, very positive signals. Unfortunately, the pivotal phase 3 trial, not so much. The control group did better than had been expected, and the renal artery denervation group, not quite as powerful of an impact as had been expected. That paused things for quite a bit. Back in these years, I understand there were as many as 70 different companies worldwide that were in pursuit of renal artery denervation as a therapeutic modality. Many of those companies went away, but a couple have persisted. Certainly Medtronic, which had invested heavily in this technology at that point, persisted on. And as you all are aware, contemporary data continue to support the argument that this radiofrequency-based renal artery denervation is associated with important reductions in the range of 10 to 20 millimeters of mercury in patients with hypertension. Studies have been done for patients with hypertension who are off their medications to understand the isolated impact of sympathetic nerve ablation, on top of their medications to look at the additive impact, both very favorable. Importantly, there's a large global registry of patients treated with this modality now, and data out of that registry continue to support the argument that there is a favorable therapeutic effect from this technology. That includes positive movement in hypertension management among patients with the usual high-risk characteristics of interest. It's also true that we have alternatives to radiofrequency ablation. As you all know, ultrasonic sonification of renal artery sympathetic nerves is also possible, and it forms the basis of the technology developed by Recor, another company that's selling product now in the United States. Very briefly, they also sham-controlled interventional studies that demonstrated that ultrasonic sonification of renal artery sympathetics in patients withdrawn from their medical treatments had favorable impact. On top of their medical treatments, had a favorable impact, including patients with highly resistant hypertension who are on 3 or more medications. The degree of systolic blood pressure reduction, again, falls roughly in that range of 10 millimeters of mercury or so. And importantly, it looks like the beneficial impact is durable. We have evidence that about 24 to 36 months with ultrasonic ablation of renal artery sympathetics, the blood pressure reductions are sustained. I will point out, though, that relative to the radio frequency body of data, there's much less in the way of patient numbers in these ultrasound studies, which is something to be considered. When you think about the ability to treat then renal artery sympathetic signaling either with radio frequency damage or with sonification, a reasonable question is, does it matter? Is one technology better than the other? We certainly have very little data about that, but I will share with you what we know so far. Important to point out that the ultrasound methods are the ultrasound device, a single ultrasound device available in the US, is not designed to go into the branch vessels of the renal artery. It's meant only to treat the main renal artery segment. The radiofrequency device, on the other hand, can be placed into the more distal vessels. So does that matter? Single study, the only one I'm aware of that has compared these technologies, again, a small sample of patients that were studied, but in this study, patients were subjected to RF ablation only in the main segment, RF ablation in the main segment and the branch vessels, or ultrasonic RDN therapy in the main segment only. As you can see in this study, it did appear that ultrasonic treatment was linked to more favorable blood pressure reductions than was seen with RF interactions or treatments either in the main artery or the main artery plus the side branch vessels. Now, this is the 3-month data. That was the primary endpoint of the trial. When you followed these patients out to 6 and 12 months, there was some erosion of the blood pressure reduction impact in all segments. By 12 months, although the overall figures continued to favor ultrasonic therapy, those differences were no longer statistically important. This, of course, is by that time, patients have been treated with their RDN therapy and have had drug therapy titrated in order to try to achieve maximal blood pressure control. The last thing I want to comment on is a low-tech approach to managing hypertension. We have in the United States, and I suspect it's very much the same here in Korea, had a pattern of seeing patients in the hospital or in the office, implementing a care plan, sending the patient home, seeing them back in a month or 3 months or 6 months, checking how they're doing, making adjustments, and repeating that cycle. As a result, a condition like hypertension can have many, many cycles of repeat office visits before we actually can establish maximally tolerated doses of guideline-directed medical therapy. In fact, it's been estimated that as many as 7 or 8 office visits are typically required, and if those are happening at, say, 1 to 3 month intervals, it can be a year to several years before we actually achieve the maximally tolerated doses of guideline-directed medical therapy. A company was developed 3 years ago or so called Story Health, a startup company out of the Silicon Valley of California. In fact, the principal behind this is a gentleman who came out of Verily, the health wing of Google. And the concept was really very simple. What would happen if we created a layer of contact that existed between the healthcare caregivers, the healthcare providers, and the patients at home? What if we put in a layer of health coaches, advocates, nurses, who could oversee the initiation of new drug dosing and help accelerate the progress toward maximally tolerated doses of guideline-directed medical therapy? Would it matter? Would it really help us get to the objective levels of drug therapy in a faster timeline? And would that yield any clinical results? The model then for Story Health is to test that. And the idea here is that patients with specific disease conditions are enrolled into a program. They're then sent home with remote patient monitoring devices. The patients are contacted by nurses, technicians, support personnel, health coaches, and the like. The information from the remote patient monitoring devices are reviewed, and when appropriate, algorithmic escalation of drug therapies are followed so that the patients have a ramp up on their medical therapies much faster than they would customarily see. Those medication titrations are done as said per algorithm, so nothing out of the ordinary is expected to happen, and all information about how the patient's doing and where the patient is on the trajectory of their drug therapies is sent electronically back to the healthcare providers directly into their electronic health record. Now, we have not at Christiana Care had an opportunity to test this model in patients with hypertension. But we have in the past 2.5 years had an opportunity to test this model among patients who are hospitalized for an exacerbation of congestive heart failure. What did we see? Compared to patients who were not enrolled in the Story Health plan, we found that within 90 days, there was a 6-fold increase in the rate of achieving maximally tolerated doses of beta blockers, a 7-fold increase in doses of angiotensin-converting enzyme inhibitors and related drugs, and a doubling in the rate of mineralocorticoid aldosterone inhibitors. So that's good. That means that we actually did see patients get up to the target doses of these important classes of drugs faster. Did it matter? Did these patients do any different in terms of their clinical course? Well, in fact, we have seen very, very substantial reductions in one key metric, and that was rehospitalization after their discharge for heart failure exacerbation. In 2019, the U.S. average was 22%, 30-day readmission rate. Last year at Christiana Care, our organizational rate was 17% for all patients, but among that cohort being managed by Story Health, 4.5%. Now, this is a select group for sure. There are a lot of requirements to participate in the Story Health program, but I think it's proof of concept and suggests that this approach to improving the touches of patients with chronic conditions in a different way can, in fact, lead to material benefits from a clinical perspective. On the basis of these findings, we are launching now, just now, a program to have Story Health assist in the management of our patients with refractory hypertension. Look forward to being able to share those experiences with you maybe next time around. So in summary, very briefly, I'm going to note that hypertension now is the leading treatable cause of cardiovascular events and worthy of our attention. We have on the horizon now new classes of medications and device therapies that have the promise of very, very substantial improvements in our degree of control for these very difficult patients. And in fact, we should be thinking differently about the way we coordinate care. And perhaps we will see benefit with that strategy as well. Thank you very much. Again, great to be back with you.
Thank you for your nice presentation. We are now open to asking questions.
Thank you for nice presentation. Do you think the device-based therapy for hypertension is still have the role for treatment for hypertension? Do you think?
The device therapy? Yeah. So I'll tell you honestly, I think although there's been variability in the data, the preponderance of evidence suggests a beneficial effect. So I tend to believe that we will see improvements in hypertension with implementation of renal artery denervation. The challenge that we have in America is interventional cardiologists and I'm included in that group, are so enthusiastic about new technologies that we're not always as careful about selecting patients for treatment as we probably should be. A requirement at my institution for taking a patient for renal artery denervation therapy is that this patient is reviewed by a heart team equivalent that includes a panel of experts in hypertension so that we can be confident that we are not subjecting a patient to therapy until we're sure that we've given them a reasonable opportunity of control with standard therapy. I will point out that although this is our standard and this is our approach, there's an Asian consortium that includes physician experts from Korea and Japan, very importantly, I remember, China, I believe Malaysia, Singapore. And a statement was made a couple of years ago arguing not just that renal artery denervation should be an approved therapy, but that it should be considered as an initial therapy for patients. And the argument was based on the really excellent safety profile seen with renal artery denervation and the fact that, well, golly, if you can treat somebody early in the course of their disease, perhaps you can prevent years of required ongoing medical therapies that have their own problems. So that's our approach, and I'm open to learning that maybe we should change in the future.
I have a question for the Gilbesiran. So actually, the blood pressure is mainly associated with the cardiac output and vascular resistance. So most of the drugs are act on these vessels or regulate the cardiac output. So actually, calcium channel blocker and angiotensin receptor blocker is reduce the resistance, and the diuretics reduce the stroke volume. And then your new drug, that's Gilbesiran.
Yes.
Yeah. What kind of mechanism is affect or regulate the blood pressure?
Yeah, okay. Well, the Zilebesiran will, it will be like an angiotensin converting enzyme inhibitor or angiotensin receptor blocker. It will interfere with the function of angiotensinogen to angiotensin, driving the vasoconstriction and volume changes associated with that substance. But it's doing so differently. It's doing so by interfering with the production of angiotensinogen at the hepatocyte level.
Then can that drug use with the ALV-OAS inhibitor?
Oh, I see. There's no toxicity concern in using an ARB or ARNI or ACE compound together with it. The impact of this injectable small interfering RNA technology has been pretty profound. I mean, it really got started in the oncology world, where it was used to interfere with the production of proteins required for tumor growth. And it's effectively abolished the production of those proteins to the point where it's been possible to kill tumors. I have to anticipate, and although I don't know what we'll find here in the phase 3 trial, but I have to expect that the potency of this approach will be such that adding an ACE inhibitor or some such will not provide any special benefit because the angiotensinogen system is already so disabled.
Gilbesiran, that drug is, I think it takes time to control the blood pressure because from the mechanism of that drug, it takes time to control compared to any other conventional drug. What do you think about that?
Yeah, you're right. It's going to take a little bit of time to get there. That would be the opportunity, I would think, in clinical practice to titrate your other medical therapies, your calcium blockers and diuretic therapy and so forth, to perfect the target blood pressure. The good news is, once you have done that, you have 6 months of sustained benefit, which is truly remarkable in my opinion. I'm very excited about this class.
Thank you for your nice lecture. You recently explained the story health.
Yes.
Yes. I think in heart failure patients, we have to many guideline and so many guideline directed therapy and a few monitor index. I think, however, in hypertension, we have just standardized drug, and I think we have a few intervention in community. Do you explain more in detail story health in hypertension patients?
Yeah, so part of your question is, part of your comments I hear is a question, are we confident that we have adequate understanding of the right steps to take in individual patients? Can we generalize that sufficiently so that an algorithm handed to a nurse can be used to drive the appropriate medical escalation? I think the answer is yes. We do know that some drugs work better in certain ethnic groups than others, so that's an opportunity to customize algorithmic plans according to the community you're treating. We'll see. I have to admit that we've never done anything like this before, so it is a bit of an experiment. But the experience thus far in the heart failure population...
Recording in progress.
Goodness, okay. The experience in the heart failure population taught me that this approach can provide very substantial benefit. Now, we'll have to decide what is the key metric to follow for these patients. Will it just be ambulatory blood pressure? That's great. Do we want to look at whether or not this approach can actually impact rates of cardiac events, stroke, atrial fibrillation, and the like? I think that would be the perfect thing to do, but of course would take a long time and a large number of patients to study. So that's my feeling.
Who are paying for story health system currently?
Who is paying for it? Is that
paying money?
Paying money for it, yes. So there are a couple of different payment models. We use sort of a subscription model where we pay Story Health a certain amount of money to manage a certain number of patients each month. Each time that Story Health makes a change in a patient's care plan, they send that information back to the electronic health record. In the United States, if a physician looks at the information, spends time authorizing that change and documents it in the medical chart, the physician can drop a charge for having done that supervisory work. It's a lot less payment than the doctor would claim if the doctor saw the patient face-to-face in the office. But it requires, 3 or 4 minutes of time on the computer rather than a 15-minute office visit. It's better for the physician because that physician now can do other work with the time saved. It's better for the patients in many ways. So I think it's okay. I will admit that right now, for us, it's costing us more money to pay for Story Health than we're able to claim by authorizing these care changes. However, the cost of a rehospitalization after advanced heart failure in America is over $15,000 per patient. So over the course of the year, it has been a cost-saving effort. The last thing I'd like to say is we have in America a real keen focus on trying to close the gaps in racial equity. And historically, black patients in America have much higher hospital readmission rates, much higher death rates from heart failure. We have seen in our cohort under care with Story Health, we've obliterated those gaps. The readmission rate is no different between black and white patients, and we have about 35% black patients in the cohort. We haven't followed long enough to know about mortality, but at least hospital readmission rates and the rates of compliance with medical plan is the same between white and black patients with Story Health. So very excited about that.
And
Thank you. It's time to move to...
Thank you very much.
Yeah.
Thank you.
Next speech. Yeah. Come back yours. I already showed the PPT, recorded video already.
Well, good morning, everyone. I want to start by thanking the
소리가 다 커지는 거예요?
선생님 여기 소리 좀 나오게 해주십시오.
소리가 나오긴 하는데.
directors and asking me once again.
소리 좀 켜주십시오.
이게 더 안.
Well, good morning, everyone. I want to start by thanking the distinguished course directors and asking me once again to contribute to the long-running GICS meetings.
Sure. Okay, finally, we're going to hear from Dr. Malcolm Bell, Professor of Medicine at Mayo Clinic, who's going to talk to us about short DAPT. Where are the gaps?
I'm so sorry that I'll not be able to join you in person this year. It's my understanding also that Dr. Jiang will be stepping down from his current position, and so I want to take this opportunity to congratulate him on his many academic achievements and wish him all the very best in this next phase of his career and life. This morning, I'm going to give a brief recap on short DAPT, patients who undergo PCI, briefly address the definitions of bleeding and high-risk bleed patients, and in particular explore the practical aspects of providing antiplatelet monotherapy and to address the question of what gaps are there in our knowledge and what's holding us back in the implementation of these strategies, and then finally to talk about de-escalation strategies in patients who are on dual antiplatelet therapy. As you will all be aware, the benefits of short DAPT is to decrease the risk of bleeding, but without increasing the risk of ischemic events. It's become increasingly popular as a strategy to decrease bleeding with DAPT and shortening that duration. And these are just a few of the trials, many of which have come from East Asia, but also in other parts of the world, particularly in Europe and the United States. The benefits of shortening DAPT are now recognized in North America, and particularly here, in the guidelines going back now 2 or 3 years. Although DAPT is still a Class 1 recommendation to be continued for 12 months, but there is now a 2A recommendation for P2Y12 monotherapy between 1 and 3 months, particularly in patients who may be considered high risk of bleeding. And similarly, after 6 months, even aspirin monotherapy could be recommended in patients who normally would have continued dual antiplatelet therapy for 12 months. And again, this is directed at the patients who are at high bleeding risk or who have an actionable bleed. I think it's important, though, to highlight some of the caveats on all of the short DAPT trials. All were open label except the Twilight study. They were of non-inferiority design, especially for ischemic events, and were underpowered for stent thrombosis. But we all know that this is a very rare event. None of the trials compared aspirin to a P2Y12 inhibitor as monotherapy, and there was no dedicated STEMI trial. And of course, this is our highest risk our highest risk group of patients who have PCI. Interestingly, despite the fact that clopidogrel was one of the predominant agents used for P2Y12 inhibitor, none of the studies was conducted using platelet function testing or genotyping. And again, as I highlighted earlier, these trials were done predominantly in East Asians. The challenge for the clinician is selecting the optimal DAPT strategy, and particularly duration for the patient, by balancing the competing risks of bleeding and ischemic risks. The precise DAPT score is an accepted score for determining duration of DAPT, although not something that has been used for the setting of monotherapy with a P2Y12 inhibitor. It may be very obvious to the clinician that the patient is at high risk of bleeding. The bleeding may already be active and clinically obvious, but other factors to take into consideration will be frailty, older age, and chronic kidney disease. The ischemic risk is a little bit more difficult to define. We know that the risk after ACS is higher than with stable angina, and that risk is highest within the first 30 days. We may want to select patients for longer duration of DAPT if they've had complex PCI, but definitions of this vary, and it's not clear which patients would or would not benefit. So I think there is more precision needed here, and whether the answer comes from artificial intelligence, novel biomarkers, remains to be seen. And it would be nice if this risk of bleeding and ischemic risk could be integrated into a single score to tell us how to best manage our patients with antiplatelet therapy. So let's explore some of the practical aspects of implementing P2Y12 inhibitor. Let's start with the choice of antiplatelet agent. Ticagrelor as monotherapy compared to dual therapy with aspirin decreased the risk of bleeding with no ischemic penalty, as was seen in the Twilight study. The same benefits have been seen in multiple trials with clopidogrel, but a word of caution in the patients who have undergone PCI in the setting of ACS. Since the STOP-DAPT-2 ACS trial showed that clopidogrel versus DAPT just failed to meet that non-inferiority margin, mainly due to the higher risk of MI in the monotherapy group. Although in absolute numbers this was low, it was 1.6 versus 0.9%. We don't have sufficient data to make any comment regarding prasugrel as an agent for monotherapy. And the same can be said for aspirin within the first 6 months after PCI. It's important to note that to date there have been no published head-to-head comparisons of, for example, clopidogrel versus ticagrelor as monotherapy. And then the second question is when to switch to monotherapy. Should it be at 1 month or 3 months? Is even less than 30 days feasible? Well, certainly for that shorter duration, I do think we need more data. But for now, it seems safe enough to initiate monotherapy at 1 to 3 months. The vexing question, though, is whether the complexity of PCI matters. I think in many of your practices, the vast majority of your patients may actually undergo complex PCI, but how do we define this? Well, in the Twilight study and review of, or retrospective reviews of some of the published data so far, it appears that the same benefits apply using monotherapy versus DAPT in the complex PCI patients to the non-complex PCI patients. In the randomized trials, though, this contributed only 20% of subjects, and the majority of these patients had stable coronary artery disease. And we know that the long-term outcome in those patients is much better than those who have ACS. And I've already alluded to how would we define complex PCI, and everyone may have a different opinion about what determines whether PCI was complex or not. I've also mentioned that the STEMI patients are underrepresented in these trials, and so I think the bottom line here is we perhaps have to be cautious with de-escalating therapy in patients in the setting of STEMI who have had complex PCI. The role of genotyping in patients treated with clopidogrel is uncertain at this stage. There has been no randomized trial with short DAPT compared to longer DAPT. As I mentioned earlier, that has not been routine in the East Asian trials where the prevalence of these polymorphisms of CYP2C19 are highly prevalent. Poor metabolizers, though, these are the patients that we should be concerned about, and at least in the population that we see here in North America, this is about 2.5% which has been seen in a number of trials. So these are the homozygotes, and these are the ones that we should be concerned about. The duration of P2Y12 monotherapy remains uncertain, and a question would arise is, if you're on a P2Y12 inhibitor, what if a surgical or endoscopic procedure was needed? Would it be as safe on a P2Y12 inhibitor versus aspirin? And what about long-term secondary prevention, let's say after 1 year? Well, the Panther collaborative group presented the largest meta-analysis and the most comprehensive synthesis of individual patient data from randomized trials investigating the comparative effects of a P2Y12 inhibitor versus aspirin, exclusively in patients with established coronary artery disease. And 2 of these trials were PCI trials, including the host exam trial. So in this meta-analysis of over 24,000 patients, most of these patients were receiving clopidogrel, the remainder ticagrelor. And you can see here that in the P212 inhibitor group, that the risk of death, myocardial infarction, and stroke was significantly lower with P2Y12 inhibitor monotherapy. This was mainly in the main benefit was actually in decreasing MI. Major bleeding was the same, and overall the net adverse clinical events were lower in the monotherapy group of a P2Y12 inhibitor rather than aspirin. And this is just a quick visual representation and summary of the benefits of a P2Y12 inhibitor over aspirin with respect to all of these endpoints here, all favoring treatment with a P2Y12 inhibitor. An intriguing discussion point is noting that the landscape of antiplatelet therapy in PCI patients has changed significantly over the last 20 years. So one question to ask is whether the benefits of prasugrel and ticagrelor over the clopidogrel shown in ACS trials 18 to 20 years ago are still relevant to today. Remember, for example, in the Plato trial, only 64% had PCI and 40% were with bare metal stents. Other patients just underwent bypass surgery or medical therapy, and only 18% had drug-eluting stents. And when we think about bleeding risks, the transradial approach is now dominant, and we see much less bleeding. We see earlier reperfusion and revascularization of our patients with better outcomes. There is undeniably better medical therapy, particularly with high use of high-dose, high-potency statins, with increased efforts on lifestyle modification. And I think we all have to acknowledge that stents got so much better, with stent thrombosis rates anticipated to be less than 1% for almost all of our patients. And so the question I would pose to you is, would the results of Plato and Triton be replicated today? And in fact, large cohort studies have really now questioned whether we see benefits of ticagrelor, for example, over clopidogrel in modern day populations. And the results are very surprising in that there does not appear to be a significant benefit of ticagrelor over the clopidogrel. And further, with the Talos MI trial, another South Korean study, de-escalating from ticagrelor with aspirin to clopidogrel within the first 30 days. You can see here that in the patients who all started with treatment with ticagrelor and aspirin, that they were then randomized to then either stay on ticagrelor or switch to clopidogrel within those 30 days. And you can see that the benefits were resoundingly more in the patients who had been switched to clopidogrel rather than ticagrelor with respect to the primary endpoint, CV death, MI or stroke, bleeding significantly reduced, and again we can see stent thrombosis rates that are extremely low. And the number needed to treat to achieve the benefit and primary endpoint was only 28 patients. Bleeding risk reduced with treatment of only 38 patients, and ischemic events which were lower only needed to treat 100 patients. So this really tells us that de-escalating fairly quickly from ticagrelor to clopidogrel was not harmful and in fact was beneficial in patients who had MI and treatment with So what algorithmic approach are we going to take to our patients? And on this slide, I've tried to simplify things just in terms of broad understanding and broad vision of our patients. The first thing is to assess whether the patient is at high bleeding risk. If not, if there's a high ischemic risk, then it would seem reasonable to continue with standard adaptive duration. But if they're not at high ischemic risk, it may be very reasonable to switch to monotherapy and shorten that DAPT period, not to expose the patient to higher risk of bleeding. On the other hand, if they're already at high risk of bleeding, if there's no high ischemic risk, then short DAPT, that should be a fairly easy decision to make today. If they are at high ischemic risk, then I think this is a question that we still need to answer, standard or short DAPT, in terms of whether or not we're going to affect that ischemic risk by shortening DAPT. And I think this is a question that remains unanswered at the moment. This slide summarizes the implications of short DAPT and de-escalation in simplifying the antiplatelet therapy after PCI. We should be confident of shortening DAPT or de-escalating if we have a patient with bleeding or is at high bleeding risk. The relative safety of aspirin or P2Y12 inhibitor monotherapy for urgent surgery, I think, remains to be determined. However, short DAPT should be the default for low-risk patients, but be cautious with those ACS patients. Have faith in the stent, and along with guideline-directed medical therapy for secondary prevention, our major goal after PCI should be to minimize bleeding risk. My take-home message is to use less aspirin, and I want to thank you for your attention today. And again, I'm sorry that I'm not there in person. I really appreciated the friendship and hospitality of all of my Korean friends and colleagues over the years. Enjoy the rest of the meeting.
Is Dr. Bell online now? He's not here. 닥터 벨 선생님이 온라인 접속해 있어요? 닥터 벨 선생님 온라인 접속 안 돼 있어요. We can't talk to him, so we'd like to close this.
All right. Well, in fact, we've overspent the hour, so we will bring this session to a close. I am very deeply grateful to the panelists for their excellent engagement, participation, and helping us run this session. And Dr. Chung, of course, always a tremendous pleasure to sit next to you. I always learn so much. Thank you, everyone. Enjoy the rest of the conference. That was great.
Great
job.
Great.
Great.
됐는데요. 예, 회의 되셨죠?
안 되는데. 어? 뭐가 안 됐던가? 언제? 네. 이거 마이크 안 돼. 마이크 돼요?
되는 건가요? 네.
이거 불이 안.
어휴. 예. 예.
문혜준 선생님, 그 닥터 오가와 선생님 원에 들어와 계신가요?
네. 아, 슬라이드가 있어요. Okay. So time is up. Would you like to start in the AMI 2 Kamil Jamil Symposium? So we have I am Young-gun. I'm from Jeonnam National University Hospital. My co-chairperson is the Kim Won from Gyeonggi University Hospital, and then Sunichi Miyazaki from the Saiseikai Dondabayashi Hospital in Japan. So it's my great honor and pleasure to have like Kamil Jamil Symposium, and the last speaker actually is Tamil from Taiwan. So we have 3 different countries in some AMI registry, the status we can know in this symposium. So we have 6 panelists: Teruo Noguchi from National Cardiovascular Center, the Kenasuke Nishihira from the Miyazaki Medical Association Hospital, Yu Kataoka from National Cerebral Cardiovascular Center, and then Lee Yong-gyu from Jeonnam National University Hospital, Bae Jang-won from Chungguk National University Hospital, Lee Jin-bae from Daegu Catholic University Hospital. Please come to the stage. And then actually we invite in the very special guest from the foreign in Japan, the Kumamoto University, Hisawa Okawa. So Hisawa Okawa, can you hear me?
Okay, thank you.
Thank you. Oh, nice to meet you. Please make some opening remarks.
Okay. Good morning, ladies and gentlemen. Can I start? Okay.
Yes.
Okay.
Okay. I would like to begin the opening remarks of the Kamira Jamila.
Ogawa Sensei, 1 second, please.
Okay.
슬라이드 화면 열어주십시오. Now, thank you.
Okay. I would like to begin the opening remarks of the Kamira Jamila Symposium. First of all, I would like to thank Professor Myung-ho and Young-Ken An, Satoshi Yasuda, for giving me the opportunity to speak at this symposium. Asian populations have different genetic and medical environment backgrounds compared to those of Western populations. However, there has been insufficient, it's insufficient real-world data on myocardial infarction patients specific to Asia. Therefore, the Jamila group has initiated a nationwide myocardial infarction registry to generate evidence specific to the Japanese population. Next slide. We initially established retrospective registry of the 2011. In 2015, we also established prospective registry. Using the prospective Jamila data set, we have reported the ischemic and bleeding outcomes of patients treated with adjusted dose Blackwell and Clopidogrel in Japanese AMI. Slide, okay?
Yes.
Next slide. Next slide, please. In addition, Jamila group have reported the real-world data of Japanese AMI patients from prospective and retrospective AMI registry. Okay. And next slide, please. The history of Jamila has been built by learning from the great success of Kamira. Jamila group invited Professor Myung-ho to annual meeting of Japanese College of Cardiology in 2012. Since then, the friendship between Jamila and Kamira continued more than 10 years. Every year, have common purpose, which is the development of original evidence for Asian AMI patients. Okay, next slide please. Therefore, Jamila and Camila team are planning collaborative work. Directors focus for the patients belong to them. Okay, using the branch dataset of Jamila and Camila, we plan to analyze ischemic and bleeding outcomes between adjusted dose 3.75 mg and standard dose 10 mg transfer. We also plan to conduct validation study of valve bleeding scale and development of the new risk prediction model by AI. These analyses will provide important evidence for East Asian AMI patients. Among East AMI patients with AMI undergoing PCI, those administered adjusted dose Strasquel exhibited a lower risk of interstitial bleeding event than those administered standard dose Strasquel, while maintaining a comparable 1-year incidence of MACE. These results were presented by Satoshi Honda and have been accepted for publication of International Journal of Cardiology 2 weeks ago, that is May 21, 24. Thank you for your attention. Thank you.
Thank you, Professor Ogawa. Thank you very much for your wonderful opening remarks. So now we are to start to the presentation. Actually, the first is from Kumamoto Miyazaki. Do you have any comment
Yes.
or say hello to some audience?
Yes, thank you so much for your nice opening remarks by Dr. Ogawa. I'm quite convinced this Jamia and Camille collaboration will be the backbone to produce the Asian AMI guideline. I believe the Asian people, the guideline, the uniform guidelines for Asian people will be published in near future. That's in that time, the Jamia Camille data will be the very, very important backbone. So this conference is quite important. Thank you so much.
Okay, thank you so much. I move the next presentations from Osok, Jeonnam National University. This topic is a recent publication from the Camille cohort. Okay, are you ready, Dr.
Thank you for your participation of this nice session. I'm Soko from Jeonnam University Hospital. I show my topic is the recent publication from the Camille Registry. As we all know, Camille Registry project was established for the memorandum of 50th anniversary of Korean Circulation Society. So this project is currently ongoing with a total of 85,066 participants enrolled. So until now, we published more than 400 Camille-based articles. So Camille team has also collaborated with the Jamila team since 2013. So we participated into Camille Jamila joint symposium in Fukuoka last year. We also met together in GICS 2023 symposium last year. So we also attended the Jamila Camille joint symposium in Osaka, Japan last year. So I show the several publications from Camille database. First of all, this study is about the comparative outcomes between RAS inhibitors in AMI with renal impairment. Among the data from the GAMIL registry, we extracted from AMI with renal impairment patients, then compared outcomes between ACE inhibitor versus ARBs. So we evaluated the long-term clinical outcomes. These studies demonstrate that the treatment with ACE inhibitors seems to be associated with better clinical outcomes than ARB treatment. Most treatments estimated include MACE, all-cause mortality, cardiac death, non-cardiac death, and non-fatal MI, and so on, were higher in ARB group than the ACE inhibitor group before and after statistical adjustments. So this is indeed the first study to compare the outcome of these two different RAS inhibitors for patients with AMI with renal impairment. So ACE inhibitors seem to be the more beneficial than their complement in this setting. Second one is about the SL2 inhibitor versus DPP4 inhibitors in AMI setting. We conducted the post-hoc analysis comparing outcomes of SL2 inhibitor versus DPP4 inhibitors among patients with AMI and concomitant diabetes. So this study demonstrated no difference between two different groups. However, LVEF improvement is significantly notable among SL2 inhibitors groups, not DPP4 inhibitors groups. So we think that this result seems to be in line with those from the IMPACT MI trial. Third one is the adjusted dose versus standard dose particular in Eastern Asian MI. Professor Honda published this article recently. Among the merged database from two different nationwide registries in Japan and South Korea, we extracted about 2,000 patients, then compared into two groups according to the dose of blood sugar. Following propensity score matching, about 7,000 patients were established for comparison between two different groups. In these studies, they underscore that adjusted dose of blood sugar showed a low incidence of major bleeding. However, MACE are very similar between two different groups. So these studies demonstrate that a reduced group of blood sugar may provide a more favorable ischemic bleeding risk balance in East Asian population. Last one is about pre-hospital delay in MINOCA. This study was a post-hoc subgroup analysis of patients with MINOCA, including two Korean nationwide cohorts, KAMIL NIJ, KAMIL 5 registry. So in this study, about 860 patients with MINOCA were finally included into this analysis. In this study, in the adjusted analysis, the incidence rates of all-cause death, cardiac death, and non-cardiac death were significantly higher in late presenters than in early presenters. Also, in the PSM matched analysis, these incidences were significantly higher in late presenters than their compartment. So this is summary. The late presenters is associated with increased 2-year all-cause mortality in patients with MINOCA. So this also underscores that multidisciplinary effort were needed to reduce pre-hospital delay, thereby improving clinical outcomes in this setting. Thank you for your attention.
Thank you. Okay, Dr. Miyazaki.
Okay, so maybe if audience have some question, maybe we can accept one or two questions. It's okay? Okay. Oh, yeah, please. Dr. Honda, please.
the comparison of ACE inhibitor and ARB for patients with AMI and who complicated with renal impairment. So in your study, ACE inhibitor showed better outcomes in terms of MACE and so on. But in the JAMIA dataset, we also have similar analysis regarding the comparison of ACE inhibitor and ARB. So when we look at the incidence of heart failure readmission after AMI, the incidence of heart failure readmission was significantly lower in patients with ACE inhibitor than those with ARB. So do you have a similar result from your study? So with regard to the heart failure readmission.
Thank you for your good question. We conducted a subgroup analysis between these two different medications, ACE inhibitors versus ARB. So we concluded that ACE inhibitors seems to be more beneficial in their counterparts because these two different medications act in a different pathophysiologic ways. So, for example, ACE inhibitors act pulmonary endothelial that indirectly affect renal targets. However, ARBs seem to be more act direct. So, in renal impairment setting, we hypothesize that ARBs are less affect their pharmacological effects. So this result endorses our hypothesis. So I think that heart failure induced admission is maybe more higher in ARB group.
Okay, thank you. We have the total discussion at the last. So please, if you have some other question, we will discuss at the last. So we move to the next presentation. The title is the progress of JAMIA-CAMIA collaborative work, a view of JAMIA. So Dr. Honda, please go ahead.
Thank you for introduction, Chairperson, and thank you for having me to the CAMIA and JAMIA Joint Symposium. So today, I'm going to talk about the progress of CAMIA and JAMIA collaborative work. Can I have my presentation slide? So dual antipress therapy with a P2A2 inhibitor and aspirin is a mainstay for reducing ischemic events following acute myocardial infarction. Oh, sorry. However, antipress therapy increases the risk of bleeding events. Therefore, balancing ischemic and bleeding risk is important. Especially East Asians are reported to have different propensity to ischemic and bleeding events compared to Caucasian. As such, original evidence is required to conduct optimal antipress therapy in East Asian population. So CAMIA and JAMIA team have been working on collaborative work to establish an original evidence for East Asian patients with AMI. We have conducted several analyses regarding ischemic and bleeding events under antipress therapy. Today, I'm going to introduce results of some analysis from that collaborative studies. The first collaborative work was research regarding ischemic and bleeding risk score for East Asian patients with AMI who undergo PCI. CAMIA team developed CAMIA DAP score. In this paper, JAMIA team did validation of CAMIA-DAP score. The performance of CAMIA-DAP score in JAMIA cohort was good, both in ischemic and bleeding events. This study was published on European Heart Journal of Cardiovascular Pharmacotherapy. The second collaborative study was research regarding ischemic and bleeding outcomes under adjusted dose prasugrel and standard prasugrel in East Asian patients with AMI. As you know, we use different doses of prasugrel between Japan and Korea. In Japan, we use adjusted dose prasugrel. The maintenance dose is 3.75 milligram. On the other hand, the maintenance dose of Korea is 10 milligram. So there is this difference in dose may result in different clinical outcomes. Therefore, we conducted comparison of clinical outcomes between adjusted dose and standard of prasugrel in JAMIA and CAMIA merged dataset. From the JAMIA cohort, we include patients who received 3.75 milligram prasugrel as a maintenance dose. And from CAMIA NIH cohort, we included patients with who received 10 milligram prasugrel as a maintenance dose. We conducted propensity score matching to adjust baseline patient characteristics. Finally, we had 1,404 patients for the analysis. And when we look at in-hospital outcomes, there is no significant difference in MACE between adjusted dose prasugrel and standard dose prasugrel. However, the incidence of TIMI measure bleeding was significantly lower in the adjusted dose prasugrel than standard dose prasugrel. So this finding suggests that reduced dose of prasugrel could provide better balance between ischemic and bleeding risk in East Asian AMI patients. So I'd like to move on to another analysis regarding validation of back bleeding scale in East Asian AMI patients. So over the past several decades, availability of potent P2 inhibitor led to reduction in ischemic events. However, potent antithrombotic therapy is associated with increased risk of bleeding events. Therefore, evaluation of bleeding events is becoming increasingly important. And there is need for precise assessment of bleeding events in randomized clinical trials and registries. Although MACE is established endpoint in clinical research, there is no established bleeding endpoint because there are many definitions of bleeding events such as TIMI bleeding, ISTH bleeding, and gastos bleeding, and so on. In 2011, the Academic Research Consortium on Bleeding proposed back bleeding scale to standardize bleeding endpoint definitions in cardiovascular trials. Back bleeding scale consists of 6 types of bleeding events, type 0 to type 5. Basically, a larger number of back bleeding reflect more severe bleeding events. For example, back type 1 bleeding represents the bleeding events that is not actionable. On the other hand, back type 5 bleeding is defined as fatal bleeding. These days, increased number of clinical trials use back definition for the evaluation of bleeding events. The validation of back bleeding scale has been performed in Western populations. In the validation study, back type 3 or 5 bleeding was significantly associated with increased risk of mortality. However, the impact on back bleeding scale has not been fully evaluated in East Asian population. Therefore, the aim of this study is to investigate the relationship between defined bleeding events and mortality in East Asian AMI patients. The analysis was performed using the JAMIA and CAMIA 5 merged dataset. Breathing events of BAC type 2, 3, or 5 breathing were evaluated. So BAC type 2 was defined, according to the BAC criteria, BAC type 2 breathing was defined as any overt breathing requiring non-surgical or medical care or leading to hospitalization. BAC type 3 was defined as breathing events with drop of more than 3 grams per deciliter in hemoglobin level or any transfusion, tamponade, intracranial hemorrhage, or bleeding requiring surgical intervention. And BAC type 5 was defined as fatal bleeding. So these are patient characteristics of JAMIA and CAMIA 5 cohort. Mean patient age was around 65, about 80% were male, and the proportion of STEMI was 77% in the JAMIA and 48% in the CAMIA 5. And more than 90% of both groups received emergent PCI. And with regard to puncture site, the use of radial puncture was more frequent in the JAMIA cohorts than the CAMIA 5 cohort. And with regard to the medications, the use of prasugrel was more frequent in the JAMIA cohort, but on the other hand, the use of ticagrelor was more frequent in the CAMIA 5 cohort. These are mortality rate and bleeding events at 12 months. All-cause mortality rate was 81% in the JAMIA cohort and 6.3% in the CAMIA 5 cohort. The incidence of BAC type 2 bleeding was 2.4 and 3.8. And the incidence of BAC type 3 bleeding was 5.1% in the JAMIA and 1.5% in the CAMIA 5 cohort. So this figure shows the cumulative incidence of mortality post-bleeding events. As you can see, all bleeding events associated with increased risk of mortality. And BAC type 3 or 5 bleeding has the greatest impact, and followed by BAC 3, BAC type 2, 3, or 5, and BAC type 2 bleeding events. These are hazard ratios of BAC bleeding events for all-cause mortality. As you can see, all BAC bleeding defined bleeding events significantly increase the risk of all-cause death. And when compared to BAC type 2 bleeding events, BAC type 3 bleeding events had greater impact on mortality. And as expected, BAC type 5 bleeding, which was defined as fatal bleeding, had the most significant impact on mortality. This is analysis showing the association of BAC bleeding events with mortality according to time from the bleeding events. These are hazard ratio for all-cause death with each bleeding endpoint using patients without bleeding events as a reference. As you can see, all types of bleeding events was associated with increased risk of subsequent mortality within 30 days post-bleeding, between 30 days to 90 days post-bleeding, and after 90 days post-bleeding events. Interestingly, the impact of bleeding events on mortality was greatest within 30 days after bleeding event compared to thereafter. So in summary, in the merged dataset from JAMIA and CAMIA 5, bleeding events assessed with the BAC scale were significantly associated with the risk of subsequent death. The risk of death increased with higher BAC bleeding grades. Our results support the use of BAC bleeding scale in AMI clinical trials for East Asian AMI population. So these are conclusions from the collaborative studies. CAMIA score is a useful clinical tool to predict ischemic and bleeding risk in East Asian patients with MI. Compared to standards of prasugrel, adjusted dose prasugrel may provide better ischemic and bleeding risk in East Asian MI patients. In East Asian MI patients, bleeding events assessed with BAC scale was significantly associated with increased risk of subsequent all-cause mortality. The JAMIA and CAMIA collaborative work will continue and provide further evidence for East Asian AMI patients. Finally, the practical paper from the collaborative study has been accepted to International Journal of Cardiology last month. JAMIA members really appreciate all the CAMIA members for their great support and contribution. And in the near future, I hope to have a collaborative study with Taiwan AMI registry groups. Thank you for your attention.
Thank you so much. I'm sorry, we do not have the time, so we are moving to the next presentation. The next presentation is the title is the AHEAD score as predictor of all-cause mortality in patients with acute MI with and without acute heart failure, which will be presented by Dr. Mike Saji, who comes from Toho University Faculty of Medicine. So the Dr. Saji, please go ahead.
My name is Mike Saji, Toho University Faculty of Medicine, Tokyo. It's my pleasure and privilege to present this session. The title of my talk is AHEAD score as a predictor of all-cause mortality in patients with acute MI. This is a sub-analysis of the JAMIR. Disclosure. So as heart failure is associated with heart morbidity and mortality, an effective predicting scheme is urgently needed to identify patients at risk of adverse events. The AHEAD score system, a simple bedside clinical prognostic model validated in European and Asian populations, has been widely used to predict all-cause mortality in patients with heart failure. Owing to the success rate of primary PCI and increasing ambulance availability in Japan, in-hospital mortality has been decreasing among patients with acute MI in recent decades. In particular, the primary PCI combined with the use of drug-eluting stents and antithrombotic therapies has contributed to decreased stent thrombosis and bleeding events. Moreover, a new mechanical support device has reduced the per-procedure mechanical complication rate, resulting in stable hemodynamics with a shorter hospital stay after acute MI. However, outcome among patients with heart failure remains poor. So the aim of the study was to investigate whether the AHEAD score as a marker of heart failure could predict all-cause mortality, particularly for patients with acute MI with and without heart failure in Asian population. So overall cohort, we excluded 344 patients, and the final population was 3,067 patients. So the baseline characteristics, the median age was 69, and the three-quarter patients were a man, and 10% of them had prior IMI, and 80% had STEMI, and the three-quarter patient then had a KLIP-1 MI, and the median peak CK was 1,600. And the patient with a higher AHEAD score were more likely to have hypertension, diabetes, PAD, prior stroke, AFib, STEMI, and a greater KLIP classification. And also they had a lower hemoglobin level and eGFR. And they were more likely to have a door-to-device time more than 90 minutes. And half of the patient had MI on LAD, and almost 90% of the patient had drug-eluting stents, and in-hospital all-cause mortality was 4.8%. And 98% had a DAPT therapy during the hospitalization, and three-quarter of them had a beta blocker, and half of the patient had ACE inhibitor or ARB. And when stratified the patient according to the AHEAD score, the patient with the higher AHEAD score had a poor outcome. I mean, the all-cause mortality after the follow-up up to the 1 year. So this is a multivariate analysis, and this showed the AHEAD score is independently associated with all-cause mortality after acute MI. And this is a sensitive analysis, including the drug information listed below. Even that, the AHEAD score is associated with the all-cause mortality independently. And notably, all the medication listed here works as a protective parameter for predicting all-cause mortality. So these are the predictive performance of the head score for predicting all-cause mortality at 1 year and a rehospitalization at 1 year. The patient with a non-STEMI with a smaller peak CK had a greater area under the curve for predicting all-cause mortality and rehospitalization. So the patient with a higher head score had a worse outcome, probably because they had a more severe cardiovascular disease at baseline. In addition, the late presentation, probably due to the less serious symptom caused by a diabetic neuropathy or something, might have resulted in a longer door-to-device time in patient with a higher head score, complicating their systemic condition. For predicting both all-cause mortality and rehospitalization after MI, area under the curve were highest in non-STEMI with a small increase in CK compared with others. This is probably because of the nature of the head score originally established for patients with a heart failure in similar population. So when you look at the previous literature, the GRACE score and the TIMUR score are the major risk model for predicting all-cause mortality. And compare with these two models, the head score has a similar predictive performance for all-cause mortality and the rehospitalization. However, considering the simplicity and the ease of use, maybe the head score is more useful in the clinical situation. So in conclusion, ladies and gentlemen, the head score, a simple and validated marker of all-cause mortality in patients with heart failure, was associated with all-cause mortality in patients with acute MI 1 year thereafter. This score may be useful because of its simplicity and ease of use, particularly for patients with acute MI with heart failure. Thank you very much.
Thank you so much. So nice presentation. So we are going to the next presentation. The title is Clinical and Pathological Features of High-Risk AMI Patients, Polyvascular Disease and Inflammation, which will be presented by Professor Yasuda.
Yes, thank you very much, Professor Miyazaki and Professor Nan and ladies and gentlemen. It's my great pleasure to have opportunity for speech in this particular session. Today, I'd like to talk about clinical and pathological features of high-risk AMI patients, in particular focusing on polyvascular disease and inflammation. This slide discloses my conflict of interest. So acute myocardial infarction, MI, is a platelet-centric disease. The major pathogenesis of MI is, as you know, the lipid-rich plaque, and which ruptured and causes thrombosis. So dual antiplatelet therapy DAPT with the P2Y12 inhibitor and aspirin is the mainstay for the reducing ischemic events following MI. So over the decades, clopidogrel has been widely used as a P2Y12 inhibitor in the choice of DAPT. And the clopidogrel shows a significant interpatient variability, mainly due to a genetic variation in CYP2C19. Therefore, a new P2Y12 inhibitor, prasugrel and ticagrelor, has been developing. So we conducted Japan MI Registry JAMIR to investigate the use of antiplatelet therapy in real-world clinical practice and clinical outcome in Japanese MI patients using prospective, observational, and multi-center fashion. So in JAMIR study, in terms of DAPT, 85% of patients received prasugrel with adjusted dose for Japanese with loading dose 20 milligram and the maintenance dose of 3.75 milligram, while the remaining 50% of patients were treated with clopidogrel. The overall incidence rate of MACE was 8.3% per year, as shown in the left panel, and the incidence of rate of Berg type 3 or 5 bleeding was 5.1% per year, as shown in the right panel. We also performed the sub-analysis focusing on polyvascular disease impacting AMI patients. As shown in the center panel, the incidence of MACE was 6.8% in patients with AMI alone, shown with a blue line. For a patient with a polyvascular disease in 2 regions, AMI plus stroke or PAD, the mortality increased to 17.5%, as shown with a green line. So in cases involving all 3 regions, AMI, stroke, and PAD, the incidence reached 23.5%, as shown in the yellow line. So to improve the outcome in ACS, further study is necessary to enhance our understanding of the pathophysiology involved. So in the Prague, in particular, in response to the cholesterol crystal, activated neutrophil release chromatin from the nucleus into the extracellular space, forming a chromatin network known as the neutrophil extracellular traps, NETs. So NETs plays an important role in immune action against bacteria. But recently, NET plays a crucial role in thrombosis and inflammation cascade activation. However, the histopathological characteristics of coronary thrombus with the NET formation in AMI and the relationship of coronary flow impairment following the percutaneous coronary intervention PCI remains unknown. Therefore, we performed a multi-center prospective study. And among the AMI patients who underwent PCI with the thrombus aspiration, 53 patients with a successful thrombus aspiration were initially enrolled. So after excluding 9 patients due to the reperfusion beyond the 24 hours after the onset, AMI onset, 44 subjects were finally included for the final analysis with assessing the coronary thrombus and collecting clinical data. This shows the histological analysis for NETs in thrombus, which were bisected and serially sectioned at 5 microns. And DNA and MPO, myoperoxygenase, and sterinated histone were stained via immunofluorescence. And as shown in this panel, double stained regions with MPO and sterinated histone were identified as the NET area. And image quantified NET area relativity to the overall thrombus area. So netosis at various stages were seen, and importantly, all aspirated thrombus exhibited the NETs, 100%. And also, we can find that cholesterol crystals were observed in the thrombus in 14 cases, 32%. And it should be noted that NETs were co-localized with the cholesterol crystal by immunofluorescence imaging. And we also found that there was a positive and significant correlation between the NET area and the cholesterol crystal area. This finding supports the idea that the cholesterol crystal is an important trigger over thrombus. Important trigger of NETs. So we performed the multivariable analysis for high NETs formation. The presence of cholesterol crystals remained independent predictor. After adjusting for covariates such as age, sex, major coronary risk factors, left main over LAD region, and onset to aspiration time. And we also found that there is a significant correlation between the net area and the TIMI flow count. So this finding indicated a significant association with net and coronary flow impairment. So in summary, there is three major findings in terms of the pathogenic role of the nets in AMI. First, all thrombus aspirated from AMI exhibit the net formation. And there is a correlation between the area of cholesterol and the area of nets. And the nets were associated with the coronary flow impairment following PCI. So we speculated fundamental underlying mechanism. So nets increased fibrin network, and which which contribute thrombus in solubility and cause mechanical obstruction in the microcirculation. And also nets contribute to the vasomotor dysfunction, probably via local inflammation and anterior dysfunction. So further research is required to comprehend the net role in AMI pathophysiology and develop the safe or effective treatment. Thank you for your attention, and I sincerely appreciate for more than 10 years support from the CAMIR, and we finally make achievement of the collaborative study of publication. Thank you very much.
Okay, thank you. So we will have a discussion at the end of the session. So I'd like to introduce in the last speaker. Actually, he is not belongs to the CAMIR and the JAMIR team, but we invite him. We would like to know about how about the situation in Taiwan. So actually, Yu Chen Wang is from graduate in the National Yangmin University in Taipei. And actually, he works right now in the Asia University Hospital. He's very active in the TAMIR establishment and then to maintenance. So he'll talk about the current status and the ongoing plans of TAMIR. Professor Wang, please.
Thank you. Thank you for inviting me to have the chance to present the current status and ongoing plans of TAMIR. And regarding to the outlines of my talk, the first part, I would like to address the clinical data from previous Taiwan ASS registries. And the second part, I would like to introduce the current status and ongoing plan of TAMIR. And regarding to the previous Taiwan ASS registries, from 2004 to 2023, we have totally 5 ASS registries conducted by Taiwan Society of Cardiology in the past 20 years. And regarding to the first 3 registries, the similar common result, one of the common results is that depth for longer than 9 months was associated with lower 1-year mortality or MACE rate in the first 3 registries. And besides, in the Taiwan ASS 4 spectrum registries conducted from 2008 to 2011, we found that in STEMI patients in Taiwan, 95% received primary PCI as the reperfusion therapies. And the median door-to-balloon time was around 96 minutes during that period of time. And we further found that comparing to STEMI, non-STEMI patients was found to have higher risk of death, myocardial infarction, MI, and MACE risk. Besides, we found that regarding to the predictors of the cardiovascular risk, we found that both CHART2 and CHART-VATO scores were useful predictors for the subsequent adverse events in ASS patients in these registries. We also found CKD and in-hospital bleeding were also associated with increased MACE rate. And regarding to the penetration rate of drug-eluting stent during that period of time, only 21% of AMI patients received the drug-eluting stent deployment. However, the use of DS was associated with better clinical outcomes in ASS patients with diabetes in the registries. And furthermore, in the high-risk non-ST elevation ASS patients, that means the TIMI scores range from 5 to 7. We found that PCI within 24 to 72 hours from symptom onset is beneficial in this kind of high-risk group. And regarding to the third registry, the ACES STEM registries conducted from 2012 to 2015, we found that the percentage of dual antiplatelet therapies was nearly 100% at discharge at AMI during AMI admission. However, the DAPT prescription rates dropped to only less than 40% after 1 year of discharge. I think that the main reason is because the limitation of the health reimbursement regulations in Taiwan, because in Taiwan, in ACES patients, the DAPT prescription was only allowed for only 9 months. So I think that it is a clinical unmet need and the gap between the health reimbursement regulation and the clinical guidelines. And when we do the comparisons of the clinical characteristics in STEMI patients between the two registries in Taiwan, we found that compared to the earlier ACES full-spectrum registries, the onset to door times in the later ACES STEM registries decreased significantly from 266 minutes to 172 minutes. Besides, the median door-to-balloon times also decreased from 96 to 71 minutes, and the door-to-ECG time also decreased from 8 to 6 minutes comparing to the earlier registry. These results imply that the quality of care in ACES patients improved during this period of time. And besides, regarding to the fourth registry, the Taiwan ACES DM registries, which was conducted from 2013 to 2015, we found that the ticagrelor provided better survival benefit than the clopidogrel. And we also found that the prescription rate of GDMT and metformin were higher in STEMI patients. And it's interesting to find that the metformin was associated with lower all-cause mortality in the ACES DM diabetes populations. And similarly, comparing to the clinical outcomes in the earlier ACES full-spectrum registry and the later ACES DM registries, we also found that the later registry showed better clinical outcomes, including the death, recurrent MI, and recurrent non-fatal stroke. And when we do the comparison among the three registries, we also found that the prescription rate of the GDMT for ACES patients was significantly higher in the later two registries compared to the earlier ACES full-spectrum registry. These results all imply that the quality of care in Taiwan all improved in recent years. Regarding to the latest registries, the T4MOSA registries, the patient recruitment was just completed last year. And estimated 3,600 ACES patients were enrolled in this registry from 41 centers in Taiwan. And the main result will be published and reported next year. And then I would like to move to the current status and ongoing plans of TAMIR. And last year, TAMIS, the Taiwan AMI Society, launched an ongoing registry, the Taiwan AMI Registry, TAMIR, just learning from the experience and success from KAMIR and JAMIR. And the initial plan of this study we will retrospectively collect pre-hospital and in-hospital data for AMI patients in Taiwan from 2011 to 2022. And I think that there are some unique features of this registry. The first one is that we will collect the pre-hospital EMT data, which include the chest pain duration and symptoms, the EMT response times, and CPR duration, the number of defibrillation attempts, the pre-hospital ECG, and the pre-hospital depth prescription. And I think that the second unique features in this registry, we can do the comparison between three different P212 inhibitors, because we know that in Taiwan we have three different P212 inhibitors: the ticagrelor, the reduced dose prasugrel, 3.75 milligram maintained dose, and the clopidogrel. And in Korea, you have only ticagrelor, a higher dose prasugrel and clopidogrel. And in Japan, you have no ticagrelor, but only have reduced dose prasugrel and clopidogrel. So, therefore, I think that in this registry, we can do the comparison about the effectiveness and the safety among the three different P212 inhibitors in Taiwan. And I believe that it will be a very interesting and important data. And to learn the experience from the Kamir and Jamir. So last year in the Christmas Eve, we Tamis have raised an online meetings, the Kamir Jamir joint symposiums, and at that, during that. On that symposium, we have invited Dr. Samyep Lee and Dr. Satoshi Honda to share your experience and how you do the collaborative work in the past 20 years. And at that, I remember that, and in that online meeting, more than 500 audience have learned from your experience. So I believe that in the future we can do more collaborative work and learn from the experience of the Kamir and Jamir. And I also appreciate that the Kamir and Jamir just released your merge dataset variables to Tamir. And in this way, we can adjust our registries variables just to adjust that as to be similar as the Kamir and Jamir. I think that this step would be the cornerstone of future collaborative work between among the Taiwan, Japan, and Korea. And regarding to the ongoing plan of the Tamir and Tamis research project, and we want to do further to do some prospective registries with long-term clinical outcomes, and we also want to raise some registries for specific medical or device therapies in ACS or CSS patients. For example, for post-MI patients. And what's the optimal lipid-lowering therapy strategies? And what about the effectiveness and safety about the novel lipid-lowering therapy, just as PCSK9 inhibitor or the incretin? I think that all of them would be an interesting topic for future collaborative work. And I think that the ultimate goal of conducting the MI registry is to establish the solid Asian data, to make Asian consensus, and to develop the Asian guidelines. So the take-home messages. The first one, based on a series of registry studies over different time periods, there has been a significant improvement in the quality of care and patient outcomes for myocardial infarction in Taiwan over the past 20 years. And the ongoing AMI registries launched by the Tamis will provide new and important information in the contemporary era to explore and solve potential unmet clinical issues. And the last, the South Korea, Japan, Taiwan, and other East Asian countries should closely collaborate in clinical research and registries to produce clinical data specific for Asian populations. And I believe that this will enable the development of AMI guidelines tailored for Asian population. Thank you for your attention. Sorry, last I would like to invite every friend here to join the Global MI Congress in 2025, next year in Taipei. It will be raised on March 29th and on March 13th in Taipei, Taiwan. And I invite, I hope everyone can attend this meeting at that time. Thank you.
Thank you, Professor Wang. So I also am sure that in the Kamil, Jamil, and Tamil can read and then the Asian AMI diagnosis and treatment, and then hopefully we will make a new Asian guideline for acute myocardial infarction. So we will have a discussion right now, and then we have 6 panelists. Changwan, please come to the stage. Why you stay in the back seat? So actually, because time is limited, I'd like to make some short question, short answer, or comment is prepared.
This is Jimbili from Daegu Catholic University Hospital. I have a question to Dr. Yasuda. Thank you for your very interesting lecture. In my knowledge, usually we traditionally divide the thrombus as red thrombus and white thrombus. Usually, white thrombus is a platelet-rich thrombus, and the mechanism is usually plaque erosion, and red thrombus is fibrin-rich, the huge thrombus usually mechanism is plaque rupture. So usually your net is related to white thrombus usually in traditional knowledge, but in your data, high net result is more frequent no reflow or slow flow phenomenon. So usually, in my opinion, plaque rupture related huge thrombus is more frequently related to no reflow or slow flow, but your data is some difference. So how can you explain your mechanism of PN, your data? Yeah.
Yeah, understand your question. Volume or quality is, I think, the both are important. And of course, larger volume of thrombus may cause finally coronary microvessel impairment. It is true. But today, I'd like to provide a new aspect. So thrombus is not only just a thrombus, which cascade with inflammatory cascade, and which may cause more worse outcome or more severe impairment in the microvascular vessels. So that's a new aspect must be net formation. So from such kind of viewpoint, today I'd like to present even preliminary data.
Okay, please. So every speakers, please come to the first line in the seat, and then it's much
Can
good.
I have a question for Dr. Honda? Dr. Honda, thank you so much for your endeavors effort to make the new data, the merging Camille and Jamil. And so actually this is usual data. There is some kind of the explanation and accumulated data, the relationship between the bleeding and then MACE in AMI patient. But usually we can predict the adverse cardiac outcome in the type 3, 4, 5 back bleeding, because this always provoke the urgent admission or transfusion and then massive hemoglobin drop. But even your data in even type 2, the back bleeding also have some kind of relationship with MACE. And so this is how do you think about it? This is the direct causality to make a major adverse cardiac event, or some kind of vulnerable patient is unrevealed some confounding factors, and so this is not so causality, this is the statistical relationship. How do you think about that?
Thank you for important question. As you mentioned, for example, type 5 bleeding is fatal bleeding, so that is directly attributed to the mortality, but type 2 bleeding is relatively weak bleeding, so we have to analyze further whether the back type 2 bleeding directly associated with mortality. So the current analysis is still preliminary data, so we need to conduct baseline patient characteristics adjustment, or further analysis is required to truly analyze the impact of back type, the causal relationship between back type 2 bleeding and outcomes.
Please go ahead.
Yes, I'll give you a short comment. In the era of precision medicine, our service effort to find unique characteristics of Asian AMI patients and to establish therapeutic guidelines will give tremendous impact in practice in medicine. I'm so proud and wish Camille-Jamil collaboration would persist and expand even further to another level. Thank you.
Please. Any questions or comment from the panelists?
Dr. Honda?
Yeah.
Please.
Just speak.
I have one question. What is the most difficult issue between for unify the registry data between the two groups?
Yes, that's an important point. So there are many difficult points with regard to merging data. But so one issue is the ethical problem. So because we need to get approval from both Korea and Japan. So that's the one of most difficult issues for the merging data set. And another issue is that there's some difference in best variables between the registry. So when we look at, for example, the definition dyslipidemia between Japan and Korea, there has been some difference. So we need to check the definition of each country, and we modify some definition in our data set. So in the future, we are planning the collaborative study with Tamiya as well. So as you mentioned, we need to check the detailed variables and to conduct the future collaborative study. That's a very important point. Yeah.
I think it is very important point to merge the data set of Tamiya. Thank you.
Okay, please. Yeah. Just speak. It's okay.
I have a question about the Dr. Oh's presentation. So, second half of your presentation, you mentioned about the early and late presentation of MINOCA or MINOCA. And could you tell me the cutoff value of timing of distinguish early and late presentation? Yes. It's a cutoff time as
cutoff time. Okay. Actually speaking, we define the pre-hospital delay according to symptom to dot time. In STEM setting, we define the pre-hospital delay as symptom to dot time over 12 hours. However, in the non-STEM setting, we define this delay as symptom to dot time over 24 hours. This definition was based on our previous studies based on Camille registry. Interestingly, this MINOCA patient did not to perform primary PCI. So, however, we demonstrated that very different outcomes between early versus late presenters. Maybe we hypothesize that early initiations of medical treatment may affect this difference. Also, many inequalities such as marital status, socioeconomic status may affect this pre-hospital delay, then affect these outcomes. Thank you.
Thank you.
So, yeah, Satoshi Yasuda.
Dr. Ho, may I ask a relating question with Dr. Noguchi? I listened to your publication of a pre-hospital delay in MINOCA with great interest. And you have any data comparing pre-hospital delay in MINOCA with myocardial infarction due to the coronary artery disease, in particular female patients? I'm expected that in MINOCA, in particular female patients, pre-hospital delay must be longer than MI-CAD. So do you have any such a comparative comparison data? In particular, female.
Actually speaking, we did not further conduct subgroup analysis between female. However, we further analysis angiographic profiles demonstrating that early presenters have much coronary vasospasm than, however, late presenters has less coronary vasospasm. So this difference may affect prescribed medications profiles in these two different groups. I mean that early presenters had more calcium channel blocker. However, late presenters has more beta blockers. These different medications is maybe attributed to these different angiographic profiles. Thank you.
Satoshi Yasuda. So I have some question to you. Or no. I'd like to ask a question to you. So actually, congratulations on your prasugrel dose story. To you. So it's good news is that so many Korean interventionists right now is switch from ticagrelor to prasugrel. I think it's the reason why that the one paper is a head-to-head analysis between the ticagrelor and the prasugrel. And then so many Korean interventionists, I think that maintenance dose is 5 milligram rather than the 3.75. So do you think it might be possible to difference between the 3.75 and the 5 milligram according to like some bleeding risk? And then can we need in some prospective the clinical trial in the prasugrel dose in Korea, Japan, and Taiwan?
You mean the 3.75 versus
yes,
5 milligram?
Yeah. Because why you choose the 3.75 in Japan? Do you have some history about
I think that the important finding is that a result of stopped up to ACS. So that stopped up to ACS provide unexpected result. So short depth or with only avoiding aspirin strategy was unsuccessful in the 3.75 milligram prasugrel. So I think that 3.75 milligram for beneficial for bleeding risk, but 3.75 milligram is some disadvantage for the antithrombosis, in particular acute phase. Therefore, it is worthwhile to compare the 3.75 milligram versus 5 milligram from the primary and efficacy endpoint in the Asian population. But I can expect which is better, which is better balance between 3.75 and 5 milligram in the clinical practice.
Okay.
Therefore,
Yeah. So I'd like to make a comment from the Professor Jung. Actually, he is the founder and established the CAMIL in Korea, and also he is a very big contribution to establishment of JAMIL in Japan. Please.
Yeah, I'd expect special thanks to all JAMIL members, especially Dr. Honda and Professor Yasuda, and all JAMIL members work very hard so we can publish very interesting, important paper this week. So would you please give them to all JAMIL group to your big, good applause for them, for JAMIL group. Thank you very much.
So then I also would like to get some comment from the one also important person is Won Kim. Actually, he is current president of Korean Society of Acute Myocardial Infarction.
Thank you, Dr. Han. I have one question to Dr. Wang, because he had not any comment of question. Thank you for your nice presentation for TAMIS or TAMIL registry current status. As you commented by presentation, prasugrel, those 3.75 milligram available in Taiwan. I suggest, how about the join us, Camille Jamil database, prasugrel 3.5 milligram or 10 milligram database. I think that more powerful data in Korea, Japan, and Taiwan for the same database registries. How about you?
Thank you. I think that in Taiwan, Korea, and Japan, we have different composition of the P2R12 inhibitors, just as I mentioned in my talk. And I think that maybe if the Camille Jamil just add the data from Taiwan, I think that we can provide more data regarding to the TICA and ticagrelor, the 3.75 prasugrel, and also the prasugrel, the clopidogrel. I think that maybe we can do some indirect comparison between different doses of prasugrel and ticagrelor and clopidogrel. I think that maybe we can have a overview or have a big pictures of the P2R12 inhibitors' effectiveness and safety in Asian population. I think it would be informative, I think.
Yeah. Okay. Okay. So now it's close to the end of time. I want to comment this Jamil, Camille, and the newcomer Taiwan, Tamir. These are very, very important network in Asian area, and especially for now we are now discussing about the prasugrel 3.75 or 5 milligram. This is a practical standpoint of view. All the physicians are very interesting in which is better, and these question is directly to the beneficial for the patients, not only in the Korea, not only in Japan, but also in Taiwan and other Asian countries. The patient will be should receive the benefit from these information network. That's my opinion. And as Dr. Yasuda said, we have some experience about the prasugrel ACS study. Actually, the 3.75 is a maintenance dose, and in the case of the acute MI, we have the loading dose, the 10 milligram of prasugrel usually. But if the patient has 80 years old or more, we adjust half or 1/3 of the prasugrel. So these are practical information. We share this information in the Asian country. Most of the Asian patients of acute MI will receive the benefit, and they will be happy, and they will have a good prognosis, I hope. Thank you so much.
Before the closing remark, and I'd like to introduce Dr. An. He will be work at the president of Korean Society of Cardiovascular Intervention in Korea from July 2024. Congratulations. Do you have any comment?
Just I'd like to do my best to support in the Camille Jamil Tamil team.
Yeah, thank you. So now it's time to close. Thank you so much for the participation.
Now it's time to wrap up this session. DES1 Symposium is going to be followed here at 2 p.m. The award ceremony and luncheon symposium is going to be followed at the main arena at 12:30. The group photo will be taken after the award ceremony. Every faculty member and all attendees, please move to the main arena at 4th floor. Everyone, enjoy your lunch. Thank you.
Yeah, come to Gwangju. Thank you. And Chairman Dr. Han. Hi. How are you? Thank you for coming. Have any good news? Next year. Okay. So would you please introduce?
It's time to open DES1. Let me introduce this chairman this session, Myung-Woo Jung from Jeonnam National University, Dong-Keun Han from Cha University, and Gary Mintz from Cardiovascular Research Foundation in USA.
Okay. Also, we have 5 panelists. Would you please introduce yourself briefly?
I'm Yamanaka from Shonan Kamakura Hospital, so it's my pleasure to join this meeting.
This is Wang Daro from Shuanghe Hospital, Taiwan. It's my pleasure to join this meeting.
This is Jinbei Lee from Daegu Catholic University Hospital.
And Dr. Doi is online. And Chairman Professor Han is also online. And first speaker will be introduced by Dr. Gary Mintz.
Thank you very much. Our first presentation by Manuel Hermida Prieto is entitled New Insights into the Genetic Basis of Ventricular Fibrillation in MI Patients.
Can you hear me?
Yes,
Yeah.
we can. We can hear you,
Okay,
but we cannot yet see you.
Okay.
I have. Is that
Na-
okay?
Now we can see you. We can see many of
Okay,
you.
And now I will share the I will share. So I hope you can. Okay, are you seeing my screen?
Not yet. We saw you
Please let me.
We see you, but that's all.
Oh, Share the screen. So you should see the slide.
No,
the
we,
first slide.
we see only you.
Okay, what is happening?
Okay, take your time and
I'm following the instructions from Rachel. Maybe Rachel can help me with this, because I can see you all, but not.
I mean, one possibility is to sign off and sign back on. Sometimes
Okay,
that works.
okay. Please give me just a few seconds to do that.
okay.
Share the screen.
Okay, we see you.
And now, what about the presentation?
No, just you.
I don't know what is happening. I don't know what is happening.
Go out and try again. Uploading again.
Okay, please. I will.
Okay, okay. Take your time.
Manuel, I think it's not your fault. I mean, I tried to share the screen, and the tool says that this function is not useful for us. So yeah, available for us. So maybe it's some kind of configuration issue of Zoom. Let's see if Rachel can help us.
The technical team is solving out the problem right now. They will allow to share your screen in 1 second.
Okay, thank you. Maybe it's working now.
Yes.
Okay,
We're
good.
good. Good.
Good. Okay. Okay. Thank you. My pleasure to join all of you in this excellent meeting. And as you know, my field of work my field of work is genetics and into the cardiovascular diseases. In this case, and this year, I will share with you some of the results from my group. Now, what is happening now? I cannot.
No, we see you. We see the slides, and we hear you.
Okay, perfect. Now it's working. Okay, everything is working. So, what I wanna tell you is, is our recent work in the field of genetics, in the particular field of ventricular fibrillation in patients with AMI. Okay, as you may know, is one of the main challenges for clinicians since background. And in all of them, we did exome sequencing. So what we try to find is other genetic factors different from mutations, polymorphism, variation, or that. One of the studies is focused on copy number variation, and the other study is based on the new or in some very short those copy number variation. So, figure by several. And this standard from the human genome. We also know that the variation related to the disease also can also in order to get this the thing is you should have several. We found most of the you can find 3 or 4 or more or less combination. So what we did is to variation paperwork influence. So we established two groups of group Amy and the other group were really engineers know we found less 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 than number is one problem. Just to know that we also found that patients we found duplicate. All of these things are related. group patient is also once again we is of them the other is many also modulating the also now relating several genes. We also know that we week of the without define one of them that clearly shows we know what we know about know lower level elevation. No. Readdition patient is lower. So the lowest we found is the activity of we can postulate is that we have very low level, very low level relation. So this function of this so conclusion we were that non-conventional play a role. They have
Okay, thank you very much. Next speaker will be introduced by Professor Han.
I'm Gwangju Han from China University. I would like to introduce two speakers. Okay, the first speaker is Professor Joseon Shin from Jeonnam National University Hospital. The title of presentation is development of pro healing stent. Okay. Professor Shin.
Okay. Thank you for the kind introduction. Hello, everyone. It is very nice to see all of you again in person and online. I'd like to introduce to you our experience of developing a pro-healing coronary stent. Let's look at the background. Current DES primarily target...
Could we have the slides, please?
Oh, okay.
Good.
Yeah, okay. Current DES primarily target inhibition of neointimal proliferation, but do not promote functional arterial healing in order to restore normal vascular reactivity. Due to the introduction of current second-generation DES, these complication risk has been reduced, but it still remains to be resolved. So healing stents can be developed, for instance, using cells. There are two mechanisms for surface functionalizations on stent endothelialization. Regeneration from adjacent cells using angiogenic peptide, nitric oxide producing coating, or regeneration from blood-borne cells, such as cell capture antibodies, adhesive peptide, or using growth factors. Recently, combo stent using anti-CD3/4 antibody coating for EPC capture, in addition to sirolimus coating, showed favorable clinical outcome. Now I'd like to introduce our Korea Cardiovascular Stent Institute. It was established in 2010 in the southern part of South Korea by Professor Myung-ho Jung, and it recently moved to Jeonnam National University Hospital Biomedical Research Institute. Here we are developing various types of DES, including metal stents and bioabsorbable scaffolds. We set up the pig catheterization laboratory in 1996 for the first time in South Korea, and we have performed over 3,700 pig experiments so far. One of our major products are CNUH Tiger bare metal stent. It was used clinically for patients indicated for BMS implantation. And using this Tiger BMS platform, we further developed a novel Tiger Revolution polymer-free stent. It consists of cobalt chromium alloy of 70 micrometer thickness, and it is coated with titanium dioxide thin film measured at 50 nanometers, and it is abluminally coated with everolimus. We obtained domestic and US patents for this technology. And we produced many stent-related papers and patents. Now I'd like to introduce to you our substance P-coated stent technology. This is collaborative work between South Korea, Spain, and Germany. We held an in-person meeting at last year's GICS Symposium, and there were Professor Myung-ho Jung and Professor Young-geun An from our university hospital, and our investigators from Spain, Professor Mida, and Professor Pardo, and from Germany, Professor Chico. The main mechanisms of action of substance P includes progenitor stem cell mobilization to the site of injury, and it reduces inflammation and improves endothelialization and reduce stenosis and enhancing arterial healing. Previously, we performed substance P in an animal study to see substance P's beneficial effects in reducing ischemia reperfusion injury in a porcine model of AMI. When given intravenously, substance P successfully reduced infarct size and inflammatory markers. Substance P-coated stent consists of a bare metal stent platform coated with a mixture of MPC polymer and substance P. The two main components of substance P-coated stents are MPC polymer, which is known to have hemocompatibility and anti-thrombotic effect, and substance P is known to improve arterial healing. In vitro testing showed substance P inhibited platelet aggregation, and substance P promoted cell migration on in vitro testing. And compared to control, it promoted endothelial cell proliferation, whereas everolimus inhibited its proliferation. We performed a preliminary animal study in pig models comparing between PLGA, everolimus lutein stent, and MPC, substance P-coated stent in pig models and performed 4-week follow-up. Left panel shows metal surfaces in each stent on microscopy, and the right panel shows sustained release of everolimus over 30 days. And substance P and MPC were mixed and coated both the luminal and abluminal sides of the metal stent, and substance P was released over 14 days. And OCT examination showed improved stroke coverage compared to PLGA ES stent when MPC, substance P-coated stent, was used. Histologic analysis showed improved re-endothelialization compared to PLGA ES. Histomorphological analysis was done, and we included historical bare metal stent group because in this study, only PLGA ES was compared to MPC substance P stent. Percent stenosis was similar between PMS, and it was higher compared to PLGA ES, but MPC substance P-coated stent showed significantly reduced inflammation score and fibrin score compared to PLGA ES stent. We successfully applied for international patent PCT last year, and we published our data. Because it was a preliminary result, and we need to improve further, so we are planning to perform a proof of concept animal study using this protocol, because substance P becomes destabilized when exposed longer in room temperature. We'd like to reduce its exposure in room temperature, and we'd like to perform in vivo testing to see whether substance P-coated stent model has higher levels of progenitor cells, and we'd like to follow up longer until 8 weeks in pig models. And we'd like to compare BMS and MPC substance P stent. Now I'd like to summarize my talk. Current DAs primarily target inhibition of neointimal proliferation but do not promote functional arterial healing. We developed a novel substance P-coated stent which showed reduced inflammation and improved re-endothelialization. Further refinements are considered necessary, including optimal substance P dose, minimization of its destabilization, and proof of concept study with longer term follow-up. Thank you for your attention.
Okay, thank you. And so move on to the next topic. So the next speaker is Luis Marinas Pardo from Valencia International University, Spain. The title of presentation is hydrogel scaffold repurposing for cardiac repair. Please.
Yeah, thank you for the kind invitation to this excellent meeting. What I would like to introduce you is our present advances of new research area. I'm studying in a new center, which is Instituto de Salud Carlos III, which is located in Madrid, and it is a new center which is specifically dedicated to cell therapies and advanced cell therapies. And I'm going to talk about new hydrogel scaffolds repurposing for cardiac repair we are developing. Just to give you a brief idea, this is the campus of the center, and this is the new building, which is dedicated to advanced therapies. And we are validating a complete floor dedicated to clean rooms for the manufacturing of advanced therapies and combinational devices for human studies, for phase 1 and phase 2 studies. So it's an eminent translational center which is starting since last year. For sure, when you saw the talk, the title of the talk, for sure you thought, well, another hydrogel scaffold for cardiac repair, because this has been a hot topic during the last decade. As you know, one of the main objectives of advanced therapies and regenerative medicines is how to achieve therapeutic heart regeneration after myocardial infarction. And even with our efforts during the last decade, so all these strategies have gained a lot of attraction over the years, but with a very, very limited effect. And this is the point we want to try to attack. Everything started more or less after the discovery of stem cells, mainly embryonic stem cells, which has a very high efficacy but a very low safety profile. The mesenchymal stem cells entering in context with a very high level of safety, but very, very poor efficacy outcomes, and also induce pluripotent stem cells, all of them providing a high hope of using these cells in regenerating the heart. We discovered that not the cells, but also the molecules they secrete, they are the healing molecules. They have a pro-angiogenic, antifibrotic, anti-apoptotic, and also anti-inflammatory effect in many ways. But soon we also discovered that the direct implantation of the cells hasn't got efficacy, because this resulted in low level of cell survival and also retention into the myocardium. So then we moved to trying to use the cells in combination with some biomaterials. There are hundreds of different scaffolds. All of them has different biocompatibility, mechanical properties, chemical structure. Some of them are natural, some of them are synthetic. But all of these characteristics, they also impact on the delivery of the food. The first approaches were trying to embed the cells into a patch with all the drawbacks that this has, to requiring an open heart surgery and so on to apply this patch into the affected myocardium. Another way of injecting this was using injectable hydrogels, mainly with two phases, sol and gel, that became solid after injecting into the heart. This was applied in transendocardial or even intracoronary or transendocardial settings. Our aim is to combine these two approaches, to use cells embedded in a patch, but that could be applied in a non-intrusive way. Our hypothesis for the work is that mesenchymal stem cells has a lot of regenerative potential that has been shown in a lot of in vitro studies, but clinical application should be performed employing always a scaffold for support, so the direct implantation is not an option. Most scaffolds, and especially hydrogels, they remain within an experimental and preclinical setting, and they have still a lot of years to transition until they could reach a clinical setting, because they have to go on through all these safety and studies. So all of them has still a long way to the clinic. The patch applications with the cells growing in the surface have several advantages over intracoronary injection, but the linguistically approach is an enormous drawback. So what we want to do is to develop a combinational device for cardiac repair that could be minimally invasive applied, just to accelerate the reaching of the clinic. We are analyzing different scaffolds that are already in the market, that for other applications, maybe for wound healing applications, that already has a regulatory approved in some countries. So this will hasten to reach the clinic. And the preferred cell types for us is mesenchymal stem cells that we have a previous background on their use that could attach and grow into the surface. And the idea is to employ some kind of catheter system for percutaneous access into the pericardial space using this kind of heat of hydrogel that I will show you. This is the concept. I mean, to have an hydrogel scaffold with the cells growing in the surface and attached to the surface that could be implanted under the pericardium and in contact with the myocardium. So all the secretomes of the cells will be released, and the healing effect will be deployed. From the around 20 scaffolds that we have checked, only very few of them allow the growth of the cells in the surface. So it's really difficult to make the cells grow in the surface. Maybe easy to include them within the hydrogel, but it's not easy for them to grow in the surface. We have chosen two of silicone hydrogel scaffolds that cells could attach into the surface and growth, and with a sustainable growth. This image shows human mesenchymal stem cells from adipose tissue that grow into the surface. And this is a negative control, so many of the silicone hydrogels, so cells do not attach, and they got in the surface floating in the culture. We have chosen silicone hydrogel because they do not, they are not bioabsorbable. They could integrate within the tissue, but they are not bioabsorbable, so they remain in the tissue. These are some images of the cells. We have characterized the growth in the surface by means of confocal microscopy. These are sheets of the hydrogel of around 1 per 1 square centimeter, and we have so each square you can see is one field of the microscope, so we can follow all the cells growing in the surface. So we can measure the number of cells, the rate of population doublings, and so on. So everything is controlled. This is a time shift microscope image during a whole night. We have also characterized the cells by means of confocal microscopy. Here you can see the cells with different stainings, and the blue represents the nuclei. But the important thing is that you see we have going following to stain the cell cytoskeleton, so you can see these fibers into the cells. This is showing us that the cells are strongly attached to the surface of the silicone hydrogel. And if we fold the hydrogel and unfold it, the cells remain attached, and they still are alive and with good survival. We have also performed transmission electron microscopy just to check the structure of the cells and also the hydrogel surface. As I told you, this is not a biodegradable hydrogel, so we wanted to check that the hydrogel stays still with whole integrity, and here you can see the surface. So the hydrogel is not degraded. It has an naive structure as the first one for the function of the cells. One of the mesenchymal stem cells growing in the surface. Again, you can see this structure. You are not used to see this kind of images in electron microscopy. You have to believe me, but these structures are cortical cytoskeleton, which shows that again the cells are strongly attached to the surface of the hydrogel, even after folding and unfolding it. So, conclusions we have characterized silicon hydrogel scaffold, which is already in the market, which has capacity to support mesenchymal stem cells growth and attachment. This scaffold has mainly a 2D structure, which has flexibility to be folded and unfolded, and this still, the cells have still viability. This new patch opens a new way to an off-the-shelf combinational device, mesenchymal stem cells and the hydrogel with minimally invasive cardiac application. We are going to start safety studies in mice, applying it intraperitoneally, and soon we will have more data on safety and retention of the cells. Thank you very much for your attention.
Okay. Okay. Thank you very much. I'm very honored to introduce the last speaker, Dr. Chico from Germany. He will give us talk mechanism of side branch occlusion in bifurcation CTO. Dr. Chico, please.
Thank you very much. So thank you very much, Mr. Chairman, and to the committee. Okay. Thank you very much for the invitation again to this interesting meeting and for the invitation to present this interesting topic. Well, how do we advance? I lost something. How do we? No, I clicked the wrong. Let's see. Okay. Okay. How do I advance the? Okay. With the now it is working. Okay. During the PCI of a chronic total occlusion, the loss of a side branch occurs in approximately 1/5 of the cases, and it's associated with worse short and long-term clinical outcomes. So it's something we should avoid. We recently published last year a consensus from the EuroCTO Club and the EBC, European Bifurcation Club, regarding this interesting challenge combining CTO and bifurcation, which are considered, is a typical sentence, the last frontiers of interventional cardiology. And we defined for the first time the 4 or 5 mechanisms of side branch occlusion: plug shift, carina shift, subintimal shift, that we will explain later on, the dissection flap, and the intramural hematoma. And I think it's worth to have a look into that because it helps to prevent the closure or to solve it if it happens. In order to understand what we are going to explain, it's useful to understand the so-called WASP rule, which means simply wires on the same plane rule. Basically, we have 2 planes, intraplaque or extraplaque. And we should have both wires in the same plane to avoid the side branch closure or to prevent the side branch closure. Interesting. If we have a wire in the true lumen, this is like having it intraplaque. Or if we have no wire in one of the side branches, it's like having the wire intraplaque for what we are going to explain. Our recommendation is, at a meaningful bifurcation, do imaging before ballooning or stenting. If both wires in the distal branches are intraplaque, then we will not have any side branch occlusion. Or if it occludes, we can solve it with a simple kissing balloon. Interesting, if we have both wires extraplaque, both of them will not have side branch occlusion, as far as we are connecting distally with the true lumen of both side branches. This is something which is interesting to keep in mind. And the recommendation is, whenever possible, it's not possible always, to keep this WASP rule, to keep both wires on the same plane before ballooning or stenting. So let's go one by one by these 5 mechanisms. So the first 2 of them are plug or carina shift. These are similar to what happens in non-CTO cases. This is typical from intraplaque tracking, and it is triggered by the balloon or stent expansion at the main vessel. Typically, we have both wires, intraplaque, in the same plane. And this is easily solved, like in non-CTO PCI, by kissing balloon inflation or by simple side branch dilation. Let's see one example. Here we have challenging in-stent stenosis CTO with high JCTO score. As you can see here, we tried to progress with the Gaia Next antegrade, very challenging because it was very calcified. Retrogradely, we achieved the Crook score this with CM Black through a septal collateral. We succeeded to put both wires in the posterolateral. You can see here on the right that they are overlapping, they are parallel with a turnpike gold catheter. So we performed the IVUS. And on the right, you see that distally, the antegrade wire is in the true lumen. In the middle one, you see both wires on the same plane. They are both intraplaque or in the true lumen. And proximally, both wires are intraplaque. You can see them. So you are in the typical plaque or carina shift scenario. Here are the two wires in the. So after balloon dilatation in the main vessel, in the posterolateral, antegradely, we lost the posterior descending artery. This was kind of so we failed to remove the retrograde wire retrogradely to the guiding catheters. It was always moving to the posterolateral, probably because we modified the plaque and it was not possible to direct the catheter. We tried to snare it, as you can see in the figure, and it was not possible. It was too calcified and impossible to manipulate. Finally, we succeeded to rewire antegradely using a supercross angulated catheter. Then we did the kissing balloon inflation, and as we knew from the IVUS, there was no problem to regain flow in the vessel. The second mechanism is also interesting to know. It's the intramural hematoma. This is these mechanisms that we are going to explain now are so-called dissective mechanisms. We are dissecting extra plaque. And this is triggered by the accidental wire progression into the side branch. Usually we have the wires on the same plane. Usually we have only one wire because when we see the intramural hematoma is when we have regained access to our target proximal vessel or our target main vessel. The treatment is simple. It's rewiring, kissing balloon inflation, and very frequently stenting to reoppose the hematoma. Here we have one case, courtesy of Professor Lauer from Jena in Germany. This is the occlusion of a right coronary artery, and he went retrogradely and retrograde dissection and reentry, and notice how the wire, the knuckle, goes to this side branch, this right ventricular, big right ventricular side branch. So after finishing, we see a significant stenosis in a wire in a branch that was initially not so diseased. This is most likely this hematoma, intramural hematoma that we're describing. More interesting are the two remaining mechanisms, the dissection flap. This is also dissective mechanisms, typical from extraplaque tracking, and this is triggered by the intentional wire progression into the main vessel throughout the bifurcation. So this is the typical scenario where we will have in the bifurcation the wires on different planes, one intraplaque and the other extraplaque. In order to prevent it, use the image and know that this scenario is happening. If it was possible, keep in mind the WASP rule, but it is not always possible. So you have to prepare some technique or some bailout because you must know that you are going to lose that branch if you dilate in the main vessel or if you proceed implanting a device. In this scenario, you will need some perforating or reentry techniques. Let's see one example. Here we have an apparently simple CTO. It seems even tapered, although we discovered it was not like that, amplifying the image. So we gave it initially very low CTO score. Antegradally, we failed with parallel wire. The wires were losing the anatomy of the vessel, so we stopped initially. Retrogradely, we reached the PDA through an epicardial collateral. Interesting. And then we, with this reference, we succeeded to put an antegrade wire in apparently the PLA. And the retrograde wire went apparently extra plaque. This was a Gaia third wire into the distal right coronary artery. So we were preparing a reverse card at this point, and then we checked that in the PLA, the antegrade wire was in the true lumen, but around the bifurcation, you can see here that the antegrade wire is extra plaque. The true lumen is there encircled in that structure. And the retrograde wire, you can see that it's at a different plane, in the true lumen of the PDA. Interesting, on the left, you see that proximally to the bifurcation, the retrograde wire has perforated the flap spontaneously, the Gaia, and is in the extra plaque, together with the antegrade wire. So this is typical from this dissection flap, extra plaque tracking, and the wires on different planes throughout the bifurcation. This is the true lumen, as you can see in the IVUS. So we decided, noticing the connection, we easily externalized a gladius wire in the guiding catheter, and then we proceeded to dilate the PLA. We knew from the IVUS that by doing this, we were losing the PDA, but we were prepared for this scenario. Then we did a rendezvous technique on the retrograde wire. We advanced, this was a Corsair microcatheter, and then we dilated the ostium of the PDA, thus breaking the flap and achieving an optimal final result, as you can see here. And the most interesting mechanism is the so-called subintimal shift. It's also a dissecting mechanism triggered by balloon or stent expansion, like the plaque and carina shift. But notice that it is something unique, because it entails some extra plaque tracking, usually at the re-enter, when you re-enter at the bifurcation and you have some subintimal track, at least at some part of the bifurcation. You will have wires on different planes, one intraplaque or extraplaque at some part of the bifurcation or around the bifurcation. Again, to prevent imaging and WASP rule, like in all these dissective mechanisms. Important for the treatment. If you have subintimal shift, it will be refractory to ballooning. Don't panic, because you will do kissing, you will do ballooning, and you will not recover the side branch if this happens. You have to stent directly. Use the image to be sure, but stent directly. Otherwise, let's see this case. We have this ostial lesion, ambiguous cap of the LAD, with good retrograde collaterals. So we went retrogradely. The idea was doing an IVUS-guided direct wiring, but an ultimate wire spontaneously crossed the lesion and entered the antegrade catheter. So, okay, they say, okay, then we are there. We have the wire. Let's see how it happens. And now you can see from the circumflex that at the bifurcation, we are still extra plaque. And then the wire enters the lumen when we are in the middle of the bifurcation. There we are, in the polygon of confluence of the bifurcation is where the wire enters. But we have a small subintimal or extra plaque track in the case. So we decided to try, because we were almost done. We pre-dilated, and it seemed to be encouraging, as you can see here. I have asked in many CTO expert scenarios, and everybody said, I would stent at this point. This is what we did. And we decided, because we are afraid to end up stenting the left main, we decided to adjust the stent to the ostium of the LAD, what Thierry Lefebvre calls bifurcation neglection. And this is what happened. We lost the circumflex. Then we tried to balloon that quickly, and we could not regain flow in the occluded circumflex. Then this was well tolerated by the patient, so we did the IVUS. It's a pity that this video is not running. It's the only one that we could not. But I have the key image. When we are imaging from the circumflex, notice this structure. I mean, at 1 o'clock, you see like a true lumen there, which is, we will explain it with the OCT. What has happened? We have a small extraplaque track when we re-enter the true lumen at the polygon of confluence of the bifurcation. Then we expanded the extent in the subintimal space and we enlarge the subintimal space, thus occluding the ostium of the circumflex. If you try to balloon at that point, you will encounter, I mean, the balloon expands with no problem, and you think that everything is going fine, but the elastic recoil of this subintimal flap is going to close the circumflex again as soon as you deflate your balloon. We have the proof with OCT. Patient was tolerating it. After stenting the LED that we had already, here you see the flap, the subintimal flap, the expansion of the subintimal space. This is the true lumen in the stent, in the LED. This is approaching the bifurcation. You see the true lumen of the LED collapsed there. And this is the scenario exactly at the polygon of confluence of the bifurcation. This is what we are doing. And then after you have the wire keeps the access to the circumflex. Okay. And this is the left main, which was our initial main concern. After stenting the circumflex, we regain flow with no problem at all. And this is the final result. You have this funny squib-shaped prolapse, which is it is actually the true lumen sandwich in the two layers of stents. So, as a practical summary, we need to know the mechanisms for side branch occlusion at CTO bifurcation. If we did intraplaque tracking throughout the bifurcation, the most likely mechanisms are plaque or carina shift that can be easily solved with kissing balloon inflection, like non-CTO PCI. But we need to know the extraplaque tracking or dissective mechanisms, which can be the accidental progression of the side wire resulting in intramural hematoma, which usually is easy to solve. And we have to know if we have a dissection flap, which is going to exclude the side branch, and then we need to be prepared either to prevent it with WASP rule, rewiring with WASP rule, imaging-guided WASP rule, or to use some perforating or re-entry technique to solve the problem. There are several ones. And most interestingly, we must be aware of the possibility of this subintimal shift, which is refractory to ballooning, and you need to stent directly in case you cannot help it and it happens. Thank you very much for your attention. You are all invited to our meeting in Germany next week about CTO and bifurcations. It's a joint initiative from the EuroCTO and the European Bifurcation Club with a lot of experts. So thank you very much for your attention.
Okay, thank you very much for excellent presentation about the side branch occlusion in CTO intervention. So I'd like to invite 5 panelists. Do you have any comments, questions? Dr. Doi, can you hear me?
Yes, I can hear you. Hi, hello.
Okay, hello. Do you have any comments, questions?
Yeah, so I have to recommend Dr. Dawson's presentation.
Yes, please.
Yes, yes. The subsequent reduces platelet aggregation when we use the aluminum surface, right? So could you tell me again for the mechanism of the reducing platelet aggregation platelet aggregation and also the enhancement of arterial healing?
Okay, thank you for the nice question. In our study, we coated substance P with MPC polymer circumferentially, but in the future, we are considering coating it luminally and abluminally with other limus. And its main mechanism is substance P has ability to mobilize progenitor stem cells to the site of injury, and it helps improve arterial healing by enhancing re-endothelialization, and in vitro testing showed it reduces inflammation and it improves re-endothelialization, so thereby it also has the effect of reducing restenosis by suppressing smooth muscle cell proliferation.
See, thank you very much for your kind comment.
Okay, thank you very much. Dr. Yamanaka?
So may I ask one more question? Professor Singh? Yes. So your group's stent is very unique, not only to prevent neointimal hyperplasia, but also prevent functional coronary functional testing. So my question is, so how do you evaluate in the real clinical setting? So functional healing, how do you evaluate functional healing in real clinical setting?
Okay, thank you for the clinically important question. Now we are in the stage of animal confirmation. Now we'd like to compare between BMS control and substance P-coated stent in pig models, and we'd like to confirm whether theoretical benefit of substance P's mobilizing progenitor cells are demonstrated in vivo model by comparing blood levels of progenitor cells in substance P-coated stent pig versus control BMS implanted model. And one issue to be clinically used, substance P's destabilization issue should be dealt with correctly. So we'd like to minimize room temperature exposure when this product is finally manufactured. So we need to store it at low temperature, such as minus 120 degrees Celsius, and then we can bring it to the cath lab to be used for humans for about 3 to 4 weeks. But we need to confirm this in the further clinical studies in the future.
Thank you so much.
Okay, thank you. And Dr. Wang from Thailand?
I also have some questions to ask Dr. Sorry. So do you think the substance P is direct interaction with the endothelial cell or endothelial progenitor cell? So do you have any in vitro study about the endothelial cell or EPC? So which side, or do you think whether it is improve the mobilization, or it is just decrease the inflammatory response? Did it direct interaction with the endothelial cell?
Yes, the main mechanism it will mobilize progenitor mesenchymal stem cells to the site of injury, and also when coated on the luminal side, it attracts circulating progenitor cells. So it has dual action of attracting circulating progenitor cells and also mobilize progenitor cells to the site of injury. So we think when we coat substance P circumferentially, it will has dual action. But in preliminary data, it has higher percent stenosis, so we will do would like to do the proof of concept study first by comparing BMS control and our study. And if the proof of concept is confirmed, then we will find the optimal dose of substance P and then move to further study in pig models.
Thanks very much. I also have a question to ask the menu, the professor menu. Did the professor menu is online? Okay.
Yes, I think he's online.
Okay. So I was wondering, what sample is he used for evaluate the link RNA? Did he use the white blood cell or he used the myocardial cell? So it is an important factor to decide how we use it, use the result of his study in the future.
Okay, he's not.
Oh, he's not
online. So,
okay,
please
it's okay.
ask another question to Dr. Chico. Okay, Professor Jinberi.
Yeah, I have a question to Dr. Shimdo-san also. Shimdo-san. Okay, I always respect your group about developing new technology for new experimental trial, like substance P. As you know, there is endocellular healing stent like EPG capture cell already developed and good healing, but higher ISR rate, so discarded in the market. Substance P stent also similar mechanism, and I worry about substance P is very unstable material in the room temperature and moisture H2. So I worry about in the stent we coated, but first problem is preservation. Second problem is stabilize inside of stent. What do you think about that?
Okay, thank you for the important questions. Compared to a genus stent which used anti-CD34 antibody, it showed it did not show improved outcome in clinical studies, and we thought it was because of the fact that it had to capture circulating CD34 cells, which is increased when there is an acute injury, such as severe injury like AMI or burns and so on. So it was difficult to capture onto the antibody-coated stent surface the circulating CD34 cells. So its effect was relatively reduced or marginal. But in our study, we think that substance P's action is dual. It also captures circulating CD34 cells, but it also mobilizes mesenchymal progenitor cells to the site of endothelial injury when it was caused, when stent was expanded, coated with substance P on the abluminal side. So theoretically, it is beneficial in these ways, but we'd like to confirm this in animal studies. On histological studies, we showed promise because its optimal dose was not yet confirmed, but our preliminary data showed improved endothelialization compared to everolimus coating stent. And we'd like to check mesenchymal progenitor cell levels in the blood when compared to BMS control was implanted. And as for the destabilization issue, we'd like to store it in low temperature, and we'd like to bring it onto the cath lab when it is ready to be used for humans. And we presume it can be stored in room temperature up to 4 weeks, but we will confirm this later.
Okay, thank you. Professor Osa.
Sim, actually speaking, we conducted 1 month preliminary animal studies about the substance P-coated stent. So I wonder, although from the substance P enhance endocellularization, however, our preliminary study demonstrated that substance P-coated stent showed more instant restenosis compared to drug-eluting stent. So in the future, we can address this major issue about instant restenosis in substance P-coated stent.
Okay, that's why we are planning to perform proof of concept comparing BMS and substance P-coated stent. And if it is successful, we can move forward by using dual coating, luminally substance P and abluminally everolimus. That way, we could improve endothelialization while reducing restenosis. And we will try to do this in animal models in the future.
Okay, thank you. And Dr. Gary Means, do you have any comment or questions?
Yeah, just 2 comments, and I'm sorry, I'm also going to ask Dr. Sim, but the first comment is, have you followed the work of the bioadapter stent? The bioadapter stent is being developed, and the claim is that vasomotion is somewhat restored at follow-up because the stent separates into individual pieces. That's number 1. Number 2, personally, I don't think conventional in-stent restenosis is a huge problem. I think that there are many other mechanisms, and I'm not so sure that healing will fix them. In particular, neoatherosclerosis is a growing problem with stents that are in place longer and longer and longer. And we had thought that BVS would not be associated with neoatherosclerosis, but in fact it does. So the question is whether any advanced healing stent will have any impact on neoatherosclerosis, because that's really the cause of late in-stent restenosis.
Okay, thank you for your nice comments. And now we are in the stage of proof of concept comparison. So after we confirm the efficacy and benefit of substance P-coated stent, we can modify our profile by adding other substances such as limus, and we can also find optimal dose, and we can prove whether it will be applied to BRS in the future. And we hope we can use this clinically if it is confirmed, and it will be able to reduce DAPT duration as well.
Our Dr. Chico, do you have any comments regarding BVS?
Maybe regarding Dr. Min's remark, I would like to append to Dr. Sim's comment that actually the philosophy underneath this Achilles heel stent is that by promoting a faster healing, we enhance the natural inhibition of neointimal hyperplasia, which is the mechanism of restenosis that drug-eluting stents are actually dealing with. Of course, I agree with you. Neoatherosclerosis, it's an issue, and probably, we don't know, probably the substance P will not act on that. However, the fact that we are not having a drug, an antimitotic drug on the stent could act also indirectly on the neoatherosclerosis, because we know that the drug-eluting stents, it was reported in 2011 that they have higher rates of neoatherosclerosis, and it is believed because they impair the endothelium properties, and then the neoatherosclerosis is more prone to attach to the areas where the drug-eluting stent has been implanted. We don't have this antimitotic drug, so it might be that the stent goes back to the neoatherosclerotic rates reported for bare metal stents. But this is just a hypothesis.
As you know, substance P stent is not enough in the inhibition of neointima or neoatherosclerosis. So how could you overcome this problem?
How we can overcome the inhibition of
neoatherosclerosis?
The hypothesis is that having an integer endothelium, we are protecting the vessel. Of course, the stent itself, it's an insult to the endothelium, to the vessel, that probably it increases by itself the incidence of neoatherosclerosis. But the drug-eluting stents add on top of that the effect of the antimitotic drug. And by enhancing the natural healing process, we will always have the mechanical insult that the stent represents. I guess the bioadapter, even though they restore the vasomotion, the insult for the vessel is still there. And probably we still don't know how much neoatherosclerosis these bioadapters will have. I'm very keen on the idea of the bioadapter. I like this development a lot, but probably I would not expect much effect on that.
Yeah, I'm a little skeptical of bioadapter, but it's getting a lot of press.
Okay, thank you very much. Dr. Keremins, would you please give us final comments, Marie?
Well, we've had 4 very different and very interesting talks, and what I like about it is it covers from the very, very, very basic science of the genetic analysis to very, very practical clinical issues, such as what happens when you treat a CTO involving a bifurcation. None of these solves a problem, but all of them point out an important problem that needs work. So thank you.
Okay, thank you very much.
Thank you.
Now it's time to wrap up this session. From now, we will have a short break. Please feel free to use this time. The next session will start at 4 p.m. after 40 minutes from now. So may I ask you all to be back in your seats 5 minutes before the session starts. Thank you for your cooperation.
그래, 그러면 나
패널이시라서. So it's all good, right?
Good.
근데 이거 뮤트 돼 있는데? 아니 이렇게 나올 때 노트북에 소리가 스피커 내가 나오는 노트북 스피커가 빠져나가요. 왜 끄라고? 아니 이거 껐으니까 안 해도 되는데? 걔도 지금 이상해서 물어보는 거야. 한번 해보실까요? 모르겠어. 일단 안 돼, 괜찮은 걸로 일단은. 선생님. 연락 안 돼서. 내가 들어가는 거 보고 안 나가는 거 상관없거든. 저기다 들어가서 있는데. 제 마이크 그게 중요하지 않는데 사실.
저도 저쪽에 연자도 마이크 좀 주세요.
Now it's time to open the Korea-London Symposium. The first session of Korea-London Symposium is Novel Cardiovascular Stent Technologies. This session is going to be co-chaired by Myung-ho Jung from Jeonnam National University Hospital, Anthony Mather from Queen Mary University of London in UK. Chairman, please come to the front and have your seat.
Okay, before starting symposium, I'd like to invite two panelists, Dr. Les Bode and Dr. Mon Kim, and Dr. Sang-woo Kim, Dr. Dae-sung Park. Please come up to the stage. My name is Myung-ho Jung. My co-chairman will be Professor Anthony Mather. Can you hear me?
I can. Good morning, everyone. Oh, good afternoon in your case.
Okay, thank you. Would you please introduce the first speaker?
Yeah, I'm delighted to be chairing this session with you, Professor Young. This is a great adventure between London and your university and hospital in Korea. I've got great pleasure. As you notice, the program has changed a little bit. Unfortunately, Professor Martin has been taken unwell. And so our first talk for this session is my colleague, Professor Borantos, who is an interventional cardiologist here at the Barts Heart Centre and at Queen Mary University of London, who has a specialist interest in intravascular imaging. And Christos is going to talk to us about novel stent visualization methods to guide PCI. Christos, over to you.
Thank you very much, Prof, for the kind introduction and also for the invitation to participate in this meeting. My talk is on emerging technologies to guide vascularization in complex cases. We know from the studies of standalone intravascular imaging that they can improve outcomes when they are used to guide vascularization. However, the data are not consistent. In the Lumen 4 study, there was no difference in outcomes between OCT and angiography-guided PCI, and this has been attributed to the low event rate in the angiography arm. However, when we look at the data of the Nobel study, where also IVUS was used and angiography-guided vascularization in the left main stem, although the event rate was high at 5 years follow-up, the use of IVUS did not improve outcomes. Intravascular imaging can improve outcomes because it can detect common causes associated with stent failure. However, both IVUS and OCT have not only advantages but also limitations. IVUS is superior to OCT for stent sizing and minimizing the risk of stent underexpansion, and also for detecting plaques at the edge of the stent, while OCT seems to outperform to IVUS in detecting malapposition, edge dissection, lipid at the edge of the stent, uncover struts, and also that seems to be superior to IVUS for detecting thrombus, although this has not been proven in studies because of its superior resolution, and all these features have been associated with adverse events. So to overcome the limitations of both IVUS and OCT, combined IVUS system has been first introduced by Conavi. There is another prototype that was coming from Terumo, is expected to be available next year, and also Panovision from China has designed a combined IVUS OCT probe that has been undergone first-in-man studies. In the recent study published 2 years ago by the Canadian group, it has been shown that the use of IVUS is associated with low risk of underexpansion, while OCT seems to be more effective in detecting malapposition and thrombus at the edge within the stent. And these some case examples highlight this statement. Another hybrid catheter that may have a value in guiding the vascularization is the combined near-infrared spectroscopy IVUS. Near-infrared seems able to detect more accurately the presence of lipid, and therefore it can be used to avoid the landing stent in a lipid-rich plaque. This technology is already available by NIPO Infraredex and has multiple applications, especially in vulnerable plaque detection. Near-infrared spectroscopy has also been combined with an OCT catheter in the prototype designed by SpectraWave. The technology has already undergone first-in-man studies. An advantage of this technology is not only the better detection of presence of lipids, but also the increased penetration of the OCT probe that seems to be performed better in advanced plaques than standalone OCT. Fluorescence lifetime imaging relies on the assessment of the fluorescence emission time after molecules being irradiated with light. Measuring this time, we can detect different biochemical signatures and identify the presence of elastin, the presence of collagen, the presence of calcium, and also there is studies showing that we can detect the presence of lipid tissue. There is a lot of work coming from Korea in the field from a company that has been recently introduced, a daughter that has designed a film OCT catheter that has already undergone first-in-man studies, and this technology seems to be effective not only in the detection of the vulnerable plaque, but may also have a value in guiding PCI and avoiding implantation of stents in lipid-rich lung zones. Photoacoustic imaging, in my mind, is the best modality for detection of lipid. Photoacoustic relies on processing of the acoustic signal that is created after the thermal expansion of molecules that have been irradiated with light. Then, with this technology, we can detect very accurately the presence of lipid. There is studies demonstrating that in animals, and a combined IVUS OCT catheter has been designed by Erasmus University, and Kaminari is trying to bring this technology in the clinical arena. As you can see in this video, the presence of red and the yellow indicates the presence of the lipid, and you can see not only the circumferential distribution of this technology, but also you can get depth information about the location of the lipid within the plaque. Near-infrared fluorescence is one of the most promising modalities in the assessment of plaque biology. Near-infrared fluorescence relies on the use of activatable markers that can be given to the patient before imaging, and this binds specific molecules associated with the plaque pathology. These markers have the ability to fluoresce after they've been irradiated with near-infrared light, and depending on the marker that we are using, we can detect the presence of vascular inflammation by identifying different mediators of inflammation. We can assess endothelial integrity, and we can also identify, and this for me is most interesting, the presence of fibrin. The tissue has also the ability to autofluoresce, and it has been shown that the lipid and intraplaque hemorrhage autofluoresces when they're being radiated near infrared light. So this technology can also be used for vulnerable plaque detection without injection of the marker. However, in the stent area, I believe that the use of FTP11 marker is may be helpful as it can differentiate more accurately endothelial coverage from pseudo coverage caused by the deep fibrin deposition. And we know that uncovered strats has been associated with a higher risk of stent thrombosis. This has been multiple registries have shown that the uncovered strats are seen more often, is the most often finding, most common finding in patients with stent thrombosis, and there are some data showing that if you have many uncovered strats, there is a higher risk of major adverse cardiovascular events. In the DECT-OCT study, it has been shown that in the use of OCT, you can reduce the incidence of uncovered strats at 3 months follow-up, and if you have an uncovered strat of less than 6%, it's safe to discontinue dual platelet therapy, and therefore we can use this technology to identify among high-risk bleeding patients those that will benefit from a shorter DAPT with no risk of stent failure. There is a combined catheter that has been designed and has already clinical applications, and Canon is trying to bring this technology in the clinical practice. There's two catheters, one coming from actually MGH and Harvard, and the other from Korea. The specific clinical scenarios may have value, especially in lipid-rich plaques, where they have been associated with high risk of MVO, microvascular obstruction, and no-reflow. In the Canary study, where a small number of lesion causes included, the use of filtered wire was not associated with a lower risk of no-reflow. However, in the Vampire 3 study that included 200 patients with an acute coronary syndrome that had the increased lipid component as was detected by IVUS in the presence of attenuated plaque, it has been shown that there is a high risk of non-inflow and high risk of in-hospital major adverse cardiovascular events when the procedure was performed without the use of filtered wire. So there is conflicting evidence. We need further research in the field, but if we prove that the use of distal protection device reduces the risk of non-inflow and major adverse cardiovascular events, then we can use hybrid intravascular imaging to identify lipid-rich plaques that will benefit from this therapy. In calcified lesions, there is a higher risk of underexpansion and major adverse cardiovascular events. IVUS and OCT can identify lesions that will not behave well after pre-dilatation with balloons, and even stent will have underexpansion. However, if you look at the data, OCT has not been proven superior to angiography for predicting underexpansion, while IVUS has a positive predictive value of the range of 60% for predicting stent expansion. So, hybrid intravascular imaging can identify the presence of lipid within calcification and differentiate mixed plaques for purely calcific plaques. These lesions are likely to behave differently when they are pre-dilated with balloons, so it can be argued that we can use multimodality imaging to assess better plaque composition and predict the behavior of these lesions during balloon pre-dilatation, and probably identify more accurately the lesions that will require preparation with bulky techniques. Where I believe that combined imaging has a role to play is in the left main stem PCI. The event rate remains high in this population, despite the use of intravascular imaging, as has been shown not only in the Nobel study, but also in the Excel study. Combined IVUS and OCT is, in my mind, the best modality for guiding PCI left main stem lesions. IVUS can be used for stent sizing and assessing osteal lesions, while OCT can be used for wire crossing and the distal cell and evaluation of the final results. We know that based on the Optimum study, that distal wire crossing has been associated with a lower risk of malapposition, and this is likely to result in an optimal hemodynamic environment that may be associated with a lower event rate. So summarizing, there are advances in image processing over the recent years that have enabled the design of multiple hybrid technologies that can have clinical value. Some of them have already reached the clinical arena, and we're expecting to have some more new candidates in the near future. These technologies seems to be able to enable better treatment planning and assessment of the final results post-PCI, especially in challenging cases such as the left main stem PCI. In addition, the near-infrared fluorescence imaging combined with OCT can be used to better assess tender for realization and personalize probably the duration of dual antiplatelet therapy in high bleeding patients. All these comments, however, are speculations. We don't have robust evidence to support the use of hybrid imaging over standalone imaging, and further research is needed towards this direction. In addition, it is essential to develop machine learning-based methodologies that will enable fast processing of the multiple of data coming out of these catheters so as to facilitate the decision-making process in the cath lab. And with these thoughts, I will close my. Thank you very much for your attention.
Thank
you very much, Christos.
And I'll introduce the next speaker, Professor Doosan Shim from Jeonnam National University Hospital. The title of his lecture will be New Center Development of Experience at Jeonnam National University Hospital. Professor Shim, please.
Thank you, Professor Jung, for the kind introduction. I'd like to introduce to you our experience of new stent development in our university hospital and Cardiovascular Stent Research Institute. This Korea-London session is part of our continued collaboration between Korea and London. Last month, we successfully held Korea-UK collaborative seminar on the topic of smart technologies in cardiovascular disease. Korea Cardiovascular Stent Research Institute was established in 2010 and was located in the southern part of South Korea. And it has recently moved to Jeonnam National University Hospital Biomedical Research Institute. Here we are developing various types of stents, including metal stents and BRS. Professor Jung established the PIG catheterization lab in 1996 for the first time in South Korea, and we have performed more than 3,700 PIG experiments until now. And we have produced many stent-related papers and patents. One of our major products is CNUH Tiger Biometal Stent. It has an advantage of superior flexibility compared to other commercial stents. And it was approved by Korea Ministry of Food and Drug Safety in 2015, and it's been in clinical use. Using this Tiger stent is the platform. We have developed many types of drug-eluting stent. And the next major product is Tiger Revolution polymer-free stent. It's composed of cobalt chromium alloy of 70 micrometer strut size, and it is coated with thin titanium dioxide film measured at 50 nanometers, and it is abluminally coated with everolimus. Now, I'd like to show you the manufacture of a Tiger Revolution stent. The surface modification was done using the plasma reactor, and titanium dioxide was coated evenly onto the surface at 50 nanometers, and everolimus was coated by electrospinning technology. When we performed animal study in pig models with 4-week follow-up, comparing between Tiger TiO2 ES with commercial permanent polymer ES and biometal control, on histological analysis, it showed comparable outcome compared to permanent polymer ES, but fibrin score was significantly lower, suggesting its higher biocompatibility. And we obtained domestic and US patents for this technology. We expanded this study into a 6-month follow-up in pig models comparing with Zion's permanent polymer commercial ES. It has comparable outcome in terms of area stenosis, but it still has lower fibrin score, indicating long-lasting biocompatibility. We also compared this novel stent with commercial, but polymer-free sirolimus eluting stent with 6-month follow-up in pig models, and it showed better outcome in terms of percent stenosis, and re-endothelialization rate was similar at 6 months. We conducted the first in-human clinical study using our polymer-free DS. A total of 20 patients with stable or unstable angina with a single de novo native coronary lesion with reference vessel diameter between 2.25 and 4.4 and lesion length less than 40 millimeters were enrolled with a 6-month follow-up. Now let's look at the results. In baseline characteristics, the mean age was 62. Men accounted for 85%. Diabetes 35%, and unstable angina patients accounted for 95%. In the treated vessel, a lady accounted for 65%, and all patients underwent PCI using radial artery access, and all patients underwent OCT examination. Post-PCI TIMI 3 grade was achieved in all patients, and the mean stent diameter was 3.4, mean length 22.6 millimeters, and all patients received dual antiplate therapy until the end of the study. QCA showed instant late lumen loss at 0.68, and OCT examination showed there was no uncovered stent struts, and malapposed stent strut rate was low at 0.2%, and area stenosis was 29%. And there were no adverse clinical events up to 8 months. Now I'd like to introduce substance P-coated stent. It's collaboratively performed between South Korea, Germany, and Spain. And the title of the project is Achilles Heel Project. The main mechanism of substance P is to mobilize progenital stem cells to the site of injury and improve arterial healing by enhancing re-endothelialization and reducing inflammation. We conducted preliminary animal study in pig models comparing PLGA, ES, and MPC, substance P-coated stent, with 4-week follow-up. The left panel shows microscopic images of metal surfaces in each stent, and the right panel shows sustained everolimus elution over 30 days. Substance P and MPC polymer were mixed and coated both the luminal and abluminal side of the metal stent, and substance P was released over 14 days. On OCT examination, MPC substance P-coated stent showed improved stroke coverage, and histologic study showed improved re-endothelialization compared to PLGA group. Histomorphological analysis showed we included historical BMS control because in the original study, BMS group was not included. In terms of percent stenosis, MPC substance P-coated stent showed similar results, but it was higher compared to PLGA ES. But MPC A substance P-coated stent showed significantly lower inflammation score and fibrin score compared to PLGA EES. We successfully applied for an international patent PCT last year, and we published our data. Now I'll briefly go over our BRS development. Draw-coated BRS was developed using PCL by 3D printing system. When coated with sirolimus, it reduced neointimal hyperplasia and inflammation. We also developed heparin-coated BRS by 3D printing. Heparinized 3D BRS showed reduced restenosis and thrombosis and improved arterial healing. We developed PLA-based tacrolimus eluting BRS with iodine layer to improve visibility. Micro-CT study demonstrated higher visibility compared to control BRS. Recently, we developed new sirolimus eluting BRS with thinner strut at 110 micrometers coated with sirolimus. On histological analysis in pig models at 4-week follow-up, PLA sirolimus stent showed lower percent stenosis compared to absorbed control with similar inflammation and fibrin scores. We are applying a novel concept of incorporating magnesium hydroxide onto our BRS to reduce inflammation and improve re-endothelialization by neutralizing acidity caused by PLLA polymer resorption. This is the proof of concept study we are planning to perform soon. We would like to compare between PLLA BVs only and PLLA BVs coated with magnesium hydroxide with longer term follow-up until 12 months in pig models. We obtained domestic and US patents for our BRS manufacture technologies. Now, let me summarize my talk. Tiger BMS had an excellent flexibility compared to other commercial stents. Polymer-free Tiger Revolution stent showed low late lumen loss and excellent stroke coverage at 8 months in the first in-human study. A confirmatory randomized trial comparing with a contemporary DS is needed to prove its potential benefits. Improving mechanical strength and reducing profile to allow better deliverability is the major issue in BRS development, and additional biologics may help improve arterial healing and reduce inflammation. Thank you for your attention.
Okay, thank you very much for extra presentation about new stent development at Jeonnam National Hospital. Professor Ensoy Massa, would you please introduce the next speaker?
I certainly will, thank you. I've got great pleasure in introducing one of our senior academics from Queen Mary and Bart's Heart Centre. Dr. Jones has spent a lot of time and has been well received with respect to his work on the use of CT in guiding and helping angiography. So I'll hand over to Dan Jones to give us a talk about the utility of CT before and after stenting. Thanks, Dan.
Morning, thank you for the introduction. Hopefully you can see my slides and I'll then start going through the talk. I'm mainly going to talk around CT planning pre-PCI, so to guide stent deployment based on the limited data post-PCI. I will cover some of the data post revascularization generally, including grafts. Now, I think the important thing to start with in terms of CT imaging is to still be clear that CT still means different things to different people. And actually, the information you get from CT depends on who's looking at the images and what they're trying to present. And a radiologist or imaging cardiologist looking at this 3D MIP, which is available on any machine, will tell you that this is clearly uninterpretable. You can't make an assessment of the coronary arteries. There's clearly a substantial blooming artifact and extensive calcification, and you need an alternative imaging modality. Whereas if you ask an interventional cardiologist, what they think, then this gives you an awful lot of pre-planning procedural information from a stenting perspective. You know that there's a significant amount of calcification, you know you're going to need adjunctive techniques, and this is almost changing your mindset to think about how you would look at CT prior to taking a patient to a cath lab. And I'm going to cover how I think a CT can help you as an interventionist to guide your angiographic procedure, both diagnostic but predominantly stent deployment. And I think an upfront CT gives you an awful lot of information about the procedural risk assessment, so simply being able to counsel the patient prior to them hitting the cath lab table, and also enabling you to choose the kit that you're going to need to perform the procedure successfully. It will tell you how to get where you want to go in terms of the access route, in terms of whether it's radial, femoral, tells you the osteolocation of the coronaries and help guide your catheter selection, both in terms of diagnostic and guide catheter choice. It'll tell you what you're going to find when you get there. So plaque characterization, are you going to encounter a significant calcified coronary plaque, lipidic plaque, and which culprit, which vessel is the likely culprit, whether is it a CTO? All this information will be available from your pre-procedure CT. And then what to do when you get there. You'll have an idea of the bifurcation strategy and whether there's side branches involved, whether or not there's a need for upfront calcium modification. And now from CT, and I'll cover this briefly, you can get functional data in terms of physiology prior to them to give you an idea as to both the length and extent of stenting that might be required using PCI planner technology, which is all up and coming. So just to cover some of the sort of the core bits that you get from CT, it can provide an awful lot of information to help you counsel the patient in terms of if you see that there's 3 vessel disease, or a surgical pattern of disease, you can gauge a patient's interest in bypass surgery prior to them hitting the cath lab table, which may prevent a second procedure. The presence of high calcium, as I just show on that 3D MIP, means that you may consider upfront rotational atherectomy, which is a different risk profile to a non-rota case, or again, an IBL. The presence of a CTO may mean that you actually plan up front for a CTO procedure with dual access, as opposed to an ad hoc procedure, which is not recommended in any guidelines these days. And physiology, actually, from a planner perspective, you may find that the PCI isn't an attractive option. If you need to put in 90 millimeters of stent to achieve an optimal physiological or functional result, then maybe the patient should be managed medically. So to start with, how can you get there? Well, CT provides an awful lot of information to tell you if you can get 2 coronary arteries from your chosen access route. It'll tell you about disease in the subclavian, or whether or not there's a retro-aortic course of the subclavian, which will make catheter engagement very difficult, and perhaps you should think about being in the left wrist from the start rather than the right to try and take out this tortuosity. In terms of the coronary ostia, typically you would see the right coronary artery coming off around 11 o'clock, and the left main coming off around 4 o'clock. The CT scan will provide information as to whether the origins of the ostia are in this standard formation or whether or not they're more anterior, rather than using, and this will help guide your catheter selection. Rather than using a JR4, which would be your standard catheter of choice for an 11 o'clock position, you're going to be thinking of using a catheter such as an AL1, and you know about this before the patient hits the table, rather than spending 20 minutes trying to find a right coronary in an aberrant position. You can just go straight with an AL1 and target that aberrant coronary. And this would be the same if the right coronary was even more aberrant coronary coming from the left coronary cusp, or a left coronary coming from the right coronary cusp. And to know all of this pre-procedure, it makes that procedure far safer, and you're more informed before you get there. Now, from a what you're going to find perspective, we know that CT provides valuable insights into disease complexity, which will influence outcomes following PCI. So you'll establish the extent of coronary disease. It shouldn't surprise you if you have pressure dampening on engagement of the guide catheter in the left main, if the CT suggests that there's left main stenosis beforehand. It saves backing out multiple diagnostic catheters or giving nitrate and worrying whether it's real or not. You'll know from the CT. And it can potentially prevent you imaging normal vessels. A patent right coronary on a CT scan, you're trying to minimize contrast. There may be no need to image that invasively if you found the target in the LAD. It tells you the nature of the disease. If CTO, you'll establish cap ambiguity, lesion length, and presence of calcification. You can figure your CTO score prior to the patient hitting the table. And you know about bifurcation disease and whether you're likely to need 2 stents. Physiological significance can be generated from CT-FFR, and there's an image here on the bottom right corner of the screen, which just reflects the functional significance that what appears to be moderate stenosis in the mid-right, but actually it's physiologically significant with a positive CT-FFR on the distal vessel. And importantly, CT can, assuming the CT is performed appropriately, give you accurate information about the vessel dimensions and landing zones. If you want to fix normal to normal, this will be apparent on CT, and the size and length of stent can also be predicted from the CT scan prior to the patient hitting the cath lab. And here is an example. An upfront CT scan demonstrates a significant stenosis in the proximal LAD with a minimal amount of calcification at the ultium of the vessel. The corresponding IVUS images can be seen here on the middle of the screen, where you can see that there's clear, healthy landing zones where you could deploy a stent. And here is the angiographic image when the patient was taken to the lab. And an IVUS guided procedure with 1 stent was performed with a good result, all predictable from the CT before the cath lab. In terms of plaque assessment, obviously the plaque, as I've shown already, CT is very good for showing calcification. I'll talk about that more in a second, but also to tell you about lipidic plaque, which will be high risk and more likely to lead to complications in terms of no reflow and standard more fibrotic plaque. Now, CT will also give you an idea about what you're going to need when you get to the coronary arteries to perform the PCI. It'll tell you about the target vessel. Is this open? Is it a CTO? And the characteristics of that CTO, and therefore what you need to be able to fix it. So I said already, you can get physiology. It'll tell you about adjunctive techniques in terms of whether there's adherent thrombus or the need for calcium modification, and even whether or not that calcium is actually treatable by which modality. And that's more advanced CT, which I'm not going to cover in this talk. From a strategy perspective, it can tell you whether or not you're likely to be treating or getting involved in a bifurcation or 2 stents are needed, and also whether or not there's high-risk features, which may mean you want to provide upfront pharmacotherapy or consider devices to try and prevent no reflow. Now, I think one of probably the most important aspect that you're going to get from CT is the presence or visualization of calcification. We know that coronary calcification remains the Achilles heel of successful angioplasty, and multiple meta-analyses and data show that there's an adverse outcome if you fail to adequately treat calcium and under-deploy stents. And although calcium is one of the main limitations of CT because it can hamper luminal assessment, this is one of the main advantages from a PCI perspective, because the high sensitivity means that you're likely to see or overestimate calcification, meaning you're not going to you won't unprepare lesions based upon the ability to look at CT of calcium burden, arc, extension, thickness, length, and distribution. And here again, just going back to the 3D MIP, you can clearly see the presence of calcification, which arguably is easier to see on CT than other imaging modalities. And here, just looking in longitudinal views from an OCT and an IVUS and a CT, I would argue that the calcification is very, very easy to see on that CT scan, and possibly you need more training to be able to see it on IVUS and OCT. However, I think there is a synergy between imaging modalities. The CT up front will show that there's the presence of calcification, and that should tell you, even if you're not a believer in imaging every case, that you should image that case. And therefore, I think the CT and intravascular imaging will be synergistic, and CT is likely to become the method to stratify calcification. Here's just some further 3D modeling to show what can be done from CT. Now, from a physiology perspective, CT-FFR can now give you upfront non-invasive physiology to give you an idea as to whether a moderate stenosis is more significant. Here's just an image of a CT-FFR showing a positive, less than 0.8 in the distal LAD. There are now tools where you can plan the stenting strategy and look for the post-PCI physiology. And here, a stent, a 48mm stent implanted on that mid-LAD still left you with positive physiology on the planner, and it actually requires 2 stents to get a negative FFR, quite a long lesion length, and maybe this patient would be better suited with a LEMA or medical therapy. Just to finish going on CT post-revascularization and also pre from a graft perspective, we know that CT is very good at looking and assessing occluded, patent, and diseased bypass grafts, giving you an awful lot of information before a post-bypass patient hits the cath lab. enabling you to plan your procedure from an access route, enabling you to be confident to be radial because you know what grafts are there and how to find them and whether you can get there. You know where the graft ostia are on the aorta, the takeoff angles, and their relationship to the sternal wires, enabling you to predict your catheter selection. And actually, CT these days, there's data to support the fact that you can selectively choose which grafts you need to engage based upon the upfront CT information, therefore making procedures potentially shorter, better for patients and safer. And I think an occluded graft on CT, you should never need to invasively assess. Now, to look at CT post-revascularization, because there was a question about whether it's useful. I think currently, with evolving technology, there will likely be better sensitivity for CT post-PCI, but I think patients post-stenting, it's very difficult to get an accurate assessment on CT, especially for stents less than 3 millimeters. I think with a stent more than 3 millimeters, there is reasonable sensitivity for CT, but often it's very difficult to exclude significant in-stent restenosis with current scanners, especially if you get suboptimal imaging. However, we've probably all seen cases on social media or in the literature of photon counting CT. And I think this technology does have the ability to potentially be game-changing in assessing stents non-invasively with CT, because the image quality you get is just seen so far and so superior to the current technology. So I suspect in the coming years, as we see more photon counting CT, the ability to assess a stent non-invasively by CT will significantly change. To summarize, CT holds great potential for transforming interventional cardiology practice. It provides accurate and reliable evaluation of coronary artery disease, composition, distribution, and enhances our understanding of the physiological impact, providing valuable information for PCI planning. It will guide your consent, tells you what you're going to find, how to get there, and what to do about it, helping us plan better PCI strategies, reduce procedural risk complications, and, although data is outstanding, potentially improve clinical outcomes. Thank you for your time.
Okay, thank you very much. I'd like to invite the panelists for comment or questions. Dr. Rathod from King Mary University of London. Can you hear me?
Yes, I can. Thank you very much, Chairman. So I had a question for Professor Barantas, if that's okay. So great talk, Professor Barantas, on imaging. Very insightful. And I agree with you regarding the need for imaging in today's PCI. However, as you probably know, the recent large OCT trial, Illumin 4, did not reach primary endpoint, which does kind of leave a bit of doubt in a lot of interventional cardiologists' mind about use of imaging. What are your comments about this? Do we need another study, or have we got enough data to use imaging?
Yeah, thank you very much, Krishna. This is a very valid point. We have many studies, at least in the field of IVO, showing prognostic benefit. In OCT, we have only the October randomized study that has demonstrated that the use of imaging in bifurcation lesions improves outcomes. The Illumin 4 study is an outlier to the current trend. And there are some explanation for this. Different era was conducted during the COVID pandemic, which the authors have argued that this may have some effect. The event rate was quite small. It was 8.2% in the lesions that was treated with angiography. And there's also another important point is the population that was included. They included diabetic patients in a large proportion and not only complex lesions. And this may have attenuated the effect of imaging in revascularization in this setting. So if we put things, if we pull all the data together, I think we have enough evidence. The studies that are currently conducted in the field is the IMPROVE study that we expected to see in the near future, and the IVUS chip. So we are going to have some more data, and from Western studies, and one European, one American. We need to see. Definitely, the operator has an effect on the performance of intravascular imaging. This is on the value of intravascular imaging, and this has been shown in a recently published paper. And very, very skillful operators that have used intravascular imaging for many years in their career, they can predict better the vessel dimensions, and this may have some effect on the results. Also, lesion selection is important. I believe that in complex lesions, stick with data and use intravascular imaging on a regular basis.
Okay, thank
Thank
you. Professor Won Kim. Sang-Wook Kim.
I have some question and comment to Dr. Branos. Can you hear me?
Yes, please.
Thank you very much for your excellent lecture. I totally agree with you. The current intravascular imaging is not sufficient for PCI planning. I'm really worried about those kind of hybrid imaging. It's about the diagnostic accuracy and also reproducibility. What do you think about diagnostic accuracy and also reproducibility of the current novel hybrid imaging?
Yeah. For example, with regards to the IVUS OCT system, I'm expecting that the outcome of the analysis will be much more reproducible because you can use OCT to assess lumen dimensions, and you can use IVUS to assess the plaque. And we know that the reproducibility of IVUS in terms of lumen segmentation is not as good as for the external elastic membrane. And when it comes to reproducibility with regards to the chemogram, for example, coming from near-infrared spectroscopy, there are evidence that it is quite reproducible by putting the cathode twice in. And with more technology, novel technologies, such as, for example, FLIP, such as fluorescent lifetime imaging, near-infrared fluorescence, we don't have a lot of data. We are still in these technologies are their infancy. The only that we can comment on is on the association with histology. And all the histological studies support accuracy. Nevertheless, we need more research in the field. I totally agree. With the reproducibility, in terms of reproducibility for the secondary modality, we don't have evidence.
Which combination will be better? I mean, H-IVUS imaging and with OCT, or OCT with the near-IVUS, or this IVUS with the film OCT? Which one will be more beneficial for the patient? What do you think?
I think the best for the patient is the one that the interventional cardiology knows best. So we have to be confident when we're using these modalities and how to interpret them. If the interventional cardiologist is confident to report on IVUS and OCT at the same time, I would prefer to have him in the cath lab a combined IVUS catheter, because you can get. There are quite a few occasions that I had to take a second intravascular imaging catheter from the shelf because I did not have the information from the first one. And I believe that this is the technology that are more likely to penetrate the market. And nevertheless, near-infrared spectroscopy with IVUS has been also been very helpful in terms of vulnerable plaque detection. So it depends also on the application. Where are you going to use it? If you are going to use it for PCI planning, definitely IVUS. If you want to get other features, and we need more studies toward this direction, we have, for example, the recently published PREVENT study. And if you want to detect vulnerable plaques, maybe better to have a technology such as near-infrared spectroscopy OCT.
I think it may be different according to region, location, and characteristics. Professor Won Kim.
Okay. Thank you for your nice presentation, Dr. Shim. I have some interesting in your presentation, tiger evolution through eluting stent. I don't understand exactly the titanium coating. Is it not polymer? But I have some wonder the abrasion of stent coating. I mean the very severe angulated calcified region path. Do you perform the abrasion of coating without polymer in your tiger evolution stent? And then what's the role of titanium coating? Is that not polymer that? What I don't understand it. Asked some answer.
Thank you for your nice question. One of the major problems of current polymer-free DS is the burst release of drug, because there is no carrier like polymer to hold it and slowly release it. So we developed titanium dioxide coated stent, titanium dioxide, when when the stent surface was modified by plasma reactor and coated with titanium dioxide shows higher biocompatibility and improve biocompatibility, and it serves as a carrier by expressing hydroxyl groups onto the surface, and it can bind everolimus. That way, we could achieve sustained release over the 30 days, and it is completely eluted by 90 days, and about 60 days, 85% of the drug is released. So I think it could be optimal for patient application. So we used titanium dioxide to improve biocompatibility and also for sustained release of everolimus.
And then in your post-immune clinical trials, how long duration of DAPT therapy? In your theoretically, very short duration of DAPT is needed.
Okay, thank you for the nice comment. We conducted first in human exploratory clinical trial in the European guideline and also in the Korea MFDA's guideline. Exploratory first in human study is performed before confirmatory study for clinical approval. So that is usually performed in a small number of patients, even in a single arm without control and relatively short period. And most of the studies performed as the first in human clinical trials using DES was the follow-up period was 6 to 8 months, and DAPT was recommended for the minimum of 6 months. And according to the operator's discretion, up to 12 months. In our study, we suggested minimum 6-month DAPT, but the operator may have chosen 8-month DAPT in all patients, but our protocol recommended 6-month minimum.
I have a short question about it, about coating technology. You showed about substance P coated stent and the others and some nice technology. I think maybe the coating technology should be different to improve stent patency. What do you think?
Yes, that's a very important question. We coated substance P circumferentially, both the luminal and abluminal side, because it was designed to confirm its efficacy compared to BMS control, because substance P has dual action, unlike the combo stent where CD34 antibody was coated on the luminal side and capture circulating CD34 cells, which showed only marginal effect. But substance P's theoretical benefit is dual. It captures circulating CD34 cells, and it also induces mesenchymal progenitor cells to the site of tissue injury when endothelial damage was done by implanting the stent. So we used dual circumferential coating, but if it shows benefit compared to BMS control, then as you know, it showed a relatively higher percent stenosis compared to DES. So we'd like to coat it luminally and limus abluminally to reduce the stenosis further. That's our plan.
Okay, thank you. Because of time limitation, I will ask Professor Dae-Sung Park short question or comments.
Okay. Professor Do Sun-sim, thank you for the excellent lecture. Currently, developed metal-based drug eluting stents they'll have problems such as thrombosis. Therefore, substance-picoted stent that can promote re-endothelialization are evaluated as a very promising technology. The substance P stent is be useful for PCI patient with higher risk of bleeding and side effect from antiplatelet drugs and high inflammation. However, in general clinical environment, the restenosis rate is accepted to be higher compared to metal-based drug-eluting stents. Will the BVS and substance P stent be useful for all patients in clinical practice?
Okay, thank you for your question. To improve the performance of our substance P-coated stent, we need to find the optimal substance P to be coated, and we need to minimize its exposure to room temperature because of its destabilization risk. And we can also coat it luminally only, and we may add limers abluminally. And for the issue of bioresorbable scaffold, I think it will come back to the market and could be applicable to a wider population in the future. But for the moment, I think the optimal target could be younger patients with simple lesions who can tolerate longer DPT.
Okay, thank you very much. Professor Anthony Master, would you please give us a final summary and closing remark?
Yes, well, a great session. I think it's extolled the virtues of the use of both intravascular and non-invasive imaging in helping us plan our procedures and also optimize outcomes. And I think a fascinating glimpse into the future from Professor Shim with respect to new novel stent technologies, which are very exciting and I must say really innovative and great ideas. So congratulations, everyone. And with that, we will close the session and move on. Thank you.
Okay.
Now it's time to open the second session of Korea-London Symposium. The second session is Biologics, Cells and Gene Therapy. This session is going to be co-chaired by Young-eun An from Jeonnam National University Hospital, Anthony Mather from Queen Mary University of London in UK.
Okay, Anthony Martha, can you hear me?
I can. Good afternoon again, once more.
But okay, thank you. So, how are you?
Yeah, good. Nice to see you again.
So, I frankly speaking, I feel some tired that in the morning, in the morning right now it's like a very tough time to some like a PCI in the AMI patient and also something to do. Anyway, I think it's really the attractive session, the Korea-London Symposium. Session 2 is the biologics, cell and the gene therapy. So actually, unfortunately, if the second presenter is not available, so we will get 3 speakers presentation, right? Yeah, so I think it's, can I introduce it, the first speaker and then the 2 other speakers will be introduced by you. So just before the start, so could you make some comment or something to the Korean audience?
Yes. Well, again, like I said, good afternoon. I just wanted to say how grateful we are for this ongoing collaboration between London and Korea. I think specifically Professor Shum and the work that we're doing both from the research perspective, but also these conferences. I think it's really great that we're able to share the work that we're doing and our thoughts with respect to the future of interventional cardiology and cardiology in general. It's a pleasure and an honor to be invited to chair the sessions at GICS this year. And the fact that we've got two great sessions. Obviously, we've just heard the first one, which was very much more clinically focused. And now we're about to go into something that's more basic science in our discussions. So again, it's an honor and privilege to be working closely with my colleagues in Korea and look forward to future collaborations too.
Thank you. So actually, I did not introduce in the panelists. So it's three Korean, the outstanding panelists, Young Suk Kim, and the Somi Yoon, and then Seok Oh. Please come to the stage. So I introduced in the first presentation, what is the future of autologous bone marrow-derived cell therapy from the Anthony Martha in the Queen Mary University of London. So actually, your present time is 10 minutes, but you can make some extend your presentation time. So take a time and then feel free to make some presentation. Dr. Martha, please.
Thank you very much for the introduction. And this is my talk. So this is really my personal view of the last 20 years of research in this field. It's important because it also links into a project that we're setting up with Professor Shim in Korea and the future potential of what we can do working together. So autologous cell therapy, just to set the scene, really started in and around this basic research that was published in 2001 by Don Orlick and his group in America, which basically set the scene about the concept of using, in this case, allogeneic cells, but bone marrow-derived cells that were minimally manipulated and infused, as you can see in the top left panel, into the infarct zone in a rodent model. And essentially what we can see in the lower panels are the echocardiogram images, the M-mode images of, on the left, the heart function prior to the iatrogenic infarct. In the middle, the iatrogenic infarct. So here you can see they tied off the left anterior descending coronary artery, which obliterated motion in the anterior wall. And then on the right-hand side, following injection of the allogeneic cells, there was restoration of function shown by the little white arrows that you can see. And the immunofluorescence panel that you can see above suggested that cells that were labeled with EGFP, so these were in cells that were the exogenous cells injected into the infarct zone, were able to actually integrate with the existing myosin fibers, the cardiomyocytes, to produce that mosaic picture on the right-hand side, saying the co-localization of the EGFP within a myosin stain, suggesting that these bone marrow cells had actually differentiated, or some might say transdifferentiated, into a muscular phenotype that was presumably contributing to the panel at the bottom, the return of function with respect to the echocardiogram that was performed. I think one thing about our field as cardiologists is that it was noted at the time that we rapidly translated this into a clinical trial. And I think at the time, working with other groups from other specialties, it was quite clear that they were pretty much in awe of how quickly we had gone from their early work. And the seminal paper obviously led to several other basic research papers that then finally led to the publication of, again, this pivotal clinical trial by Professor Andreas Zayer from Frankfurt, in which the concept of using bone marrow-derived cells taken under local anesthetic, processed in a standard cell processing laboratory, and then infused into the infarct zone in the coronary artery, demonstrated not only improvements in cardiac function, but for the first time, a trend towards an improvement in event-free survival, as you can see on the graph on the right. The study was not powered to demonstrate a difference in morbidity and mortality, and you can see the p-value didn't reach significance. But obviously, this was incredibly promising and was a brilliant example of translation going from bench to bedside in essentially a decade. And that really set the scene for the rest of the world to start doing studies. One of the criticisms about the rest of the world approach was that everyone did things slightly differently. And what I'm showing you here is what we did here in London, in that we tried to standardize the approach to how we would process and deliver the cells. We performed a series of phase 2 clinical trials, which you can see listed at the top, Regenerate being the generic group name for the use of autologous cells, in treating different conditions with AMI, acute myocardial infarction on the left, ischemic heart disease, so patients with established heart failure and poor ejection fractions and no other options in the middle, and on the right, patients with dilated cardiomyopathy. So these were totally unobstructed coronaries, but with a pure heart muscle disease. Our program also led to the first phase 3 international academic study, the BAMI study, which I'll talk about briefly, published at and presented at the European Society of Cardiology, which again, I think is credit to the fact that we translated what we'd seen in the phase 2 clinical trials rapidly into a phase 3 clinical trial to really answer or try and answer the question as to whether autologous cell therapy has a role to play in patients straight after an acute myocardial infarction successfully treated with primary angioplasty. And in our most recent studies have basically looked at the patient population that theoretically have the most benefit from, and those are with significantly impaired cardiac function, who unfortunately are most at risk of not surviving the procedure because we use coronary artery occlusion to actually inject the cells. So the DCM support study took the results of Regenerate DCM, the dilated cardiomyopathy population of patients, and applied it to a group of patients with substantially impaired left ventricular ejection fractions, less than 30%, but supported with circulatory support in the form of an impeller CP device during the infusion procedure. The results of that are currently being analyzed. And then finally, we've branched out into a new area, which again is probably one of the answers to my question about the future of autologous cell therapy, and that is for the treatment of refractory angina, which we will talk on. So our own personal experience, this was the Regenerate AMI trial. You can see it's green, so basically it met its primary endpoint, which was within group improvement in ejection fraction. And you can see that listed or demonstrated graphically in panel A, top left. That this study showed, I guess, statistically significant, but skeptics would say only a small improvement in cardiac function. But again, as I said, met its primary endpoint and gave hope that this might well convert into a mortality benefit, as was seen in the REPAIR AMI trial. In order to establish that, we led a European consortium of 12 partner nations across Europe to basically conduct the BAMI study. And the BAMI study taught us an awful lot. This was a phase 3 study of autologous cell therapy in the context of primary angioplasty. So patients have a successful angioplasty but impaired LV function. And we set a very high bar in order to get this funding and also to convince the regulators. We were looking for a 25% reduction in all-cause mortality at 2 years. As you can see, the study basically massively under-recruited. So out of the target population of several thousands, only 375 patients recruited across the 37 European sites that were there, demonstrating some of the difficulties with competing studies, and also the fact that the target population of patients with significantly impaired LV function during acute myocardial infarction was a rapidly declining population based on the success of primary angioplasty, thereby making the initial power calculation probably inaccurate, because as you can see, the overall mortality rate in this study was only 3.5%, which essentially I think is a tribute to the success of heart attack centers across Europe. The original study was published on registry data suggesting that there was a two-year all-cause mortality of 12%. So with those figures in mind, you can see that we would have needed to have recruited 4 times as many patients, which would have taken the study up to 12,000 patients. Bearing in mind this is quite a complex study with respect to cell processing, the cost to do that would not be feasible. Where do we stand with the rest of the world? Well, in keeping with the conclusion that I think you could assume from what I was about to say, that although we do see a benefit in acute myocardial infarction, particularly in our phase 2 studies, the problem is that when we get to phase 3, the benefit is so marginal, the costs and logistics outweigh any potential benefit. And the meta-analysis here, although it only involved a few hundred patients at a time, also suggested that there didn't seem to be a long-term mortality benefit. So our conclusions about the role of autologous cell therapy in the treatment of acute myocardial infarction was that it probably wasn't worth it, but showed beneficial efficacy effects. That the acute myocardial infarction, thanks to the success of heart attack centers around the world, was probably no longer a sensible target for advanced biologics based on the cost. With respect to established heart failure in patients with ischemic heart disease, we performed the Regenerate IHD trial. Again, you can see it's green, so it met its primary endpoint for improvements in ejection fraction, which is obviously a surrogate endpoint, but was sufficient for a phase 2 clinical trial. We had up to 5% improvement in ejection fraction, and also corresponding decreases within NYHA class and NT-BNP, suggesting that this was a real effect, and we didn't need a vast number of patients, as you can see, to actually demonstrate that. Where does that information stand for autologous cell therapy with respect to the rest of the world? Again, you'll notice the numbers aren't great, but interestingly, for heart failure, particularly of ischemic origin, the meta-analysis suggests that there is a beneficial effect with respect to mortality greater than 12 months for patients receiving cell therapy. So here, as opposed to acute myocardial infarction, the rationale for continuing with heart failure. And then finally, heart failure due to a dilated cardiomyopathy cause. Again, our phase 2 trial, green tick, met its primary endpoint. Here, for the first time, showed that the endpoint of ejection fraction improvement was sustained up to 1 year and in fact improved. So we got a 5%, similar to the IHD study, improvement at 3 months, moving up to a 7% at 1 year. But what's really striking is the NYHA class and the purple panel at the bottom, in which for a randomized controlled trial in the bone marrow treated group, you can see that no patients actually got worse, and that by 1 year, 66.6% of patients in the study had actually improved their NYHA class, which is pretty unprecedented in a heart failure study and therefore very hard to ignore. Based on that, and based on our patients coming to us saying, we want cell therapy, and essentially we know that we have an increasing group of people with heart failure who are on optimal medical therapy, and this includes the latest heart failure medications, but who still have symptoms, we set up the Compassionate Treatment Unit, which is funded by a charity here at Barts. It's the only compassionate treatment center for heart failure in the whole of Europe using autologous cell therapy. And here I show you the results of the patients, in which we're seeing a 60 to 70% improvement in a group of patients where the dilated cardiomyopathy or ischemic heart disease being the etiology, who have been told there are no further treatment options. So to get into the program, they have to be fully optimized on heart failure and device-based therapy. And you can see across the board that we're seeing improvements in ejection fraction, NYHA class, 6-minute walk test, and also the quality of life scores as well, which means that obviously we will continue to offer this program. But at the moment, it's really all there is, I think, in the field, with the failure of some of the other phase 3 trials that were planned to actually get off the ground due to financial reasons. So where does that leave us? It leaves us potentially thinking about other things we can do with autologous cell therapy. The beauty of it being it's a relatively simple way of processing cells that most hospitals that have a stem cell processing unit for our hematology colleagues can actually do. What you can see here is a meta-analysis published by Dr. Jones and myself, in which we looked at the studies using cell-based therapy, particularly autologous, to look at outcomes. And you can see, interestingly, in refractory angina, that growing group of patients that, despite the complex interventions and also new technologies such as the coronary sinus reducer, seem to be increasing in our clinics. There is a potential signal for reduction in mortality and an also increase in exercise tolerance, together with a decrease in MACE. So with that in mind, again, because there haven't been that many studies in the field, in London we are conducting a phase 2 clinical trial randomized blinded study of patients, very much along the Coursera, the coronary sinus reducer study design produced in the US, but basically testing whether intracoronary injection of bone marrow-derived mononuclear cells, autologous cells, targeting the ischemic territory is going to lead to a substantial reduction. And here the primary endpoint is a reduction by two CCS classes in symptoms to our patient population. And hopefully I will be able to present the results of this study at one of the upcoming GICS meetings. So what else can we do with autologous cell therapy? I think the combination about the comment that we could use it potentially as a combination therapy and target new areas is an important one. And peripheral vascular disease still remains a growing problem around the world, in which peripheral stenting has not had as big an impact as we would imagine. So here the concept, and again linking to a project that touches on an earlier talk by Professor Shim about bioabsorbable stent technology and also cell therapy capture, is the concept that we can potentially, from a project that we designed called BioMaxCar, use a biodegradable magnetizable stent scaffold to attract magnetized bone marrow-derived cells, prepared in the same way that we did in our clinical trials, to basically target patients who have got critical peripheral vascular disease and limb ischemia, to basically restore the blood supply, as you can see in the stented cartoon at the bottom left, but also attract healing not only at the site of the scaffold, but by injecting the bone marrow-derived autologous cells, which have shown the potential to heal, to cause neovascularization in the periphery, to actually potentially save limb amputation and treat peripheral vascular disease. So just a thought on a project that we might do well to collaborate and work together on. So in summary, the future of autologous cell therapy is limited by the fact that the number of patients enrolled in clinical trials remains small and is unlikely to grow at this moment in time. Although the results are positive, I think most of our colleagues were somewhat underwhelmed, except as you can see from the London experience, it's very hard to walk away from the data that we generated because it was overwhelmingly positive across the board. And that's given us the grounds for our local experience, the compassionate unit, which will continue to treat patients as long as we see the symptomatic improvement in their heart failure symptoms. We have plans to develop this as a service development across the British National Health Service. So we're working with a spin-out company to establish a program that we can deliver this cell therapy across the UK to our heart failure patients. And excitingly, we're working with Professor Shim to basically come up with a collaborative study in which we could potentially do a similar clinical trial in Korea before, again, if successful, thinking about something that is more widespread and could be applied nationally. The final thoughts on autologous cell therapy, because for an interventional cardiologist, it offers a relatively straightforward access to the delivery of cells to patients, is we watch this space about this being a new treatment for refractory angina that can coexist with complex intervention as well as the coronary sinus reducer. The concept that, again, the simple approach of autologous cell therapy lends itself to combination therapy, such as the smart scaffold for peripheral vascular disease, and the fact that there's the opportunity to compare cells with genes to see if we can improve the cellular function, cellular modification being a key point there, because we need to optimize these cells to do what we expect them to do, which is to repair the myocardium more efficiently. And finally, one reflection with all of this is that everyone's cells are not equal. Patient selection is quite important. There are clearly responders and non-responders. And again, for the future of autologous cells, which I think still does have a future, we need to get better at selecting our patient population. So with that, I will close and say thank you very much for the opportunity to give this lecture.
Okay, thank you very much for your wonderful presentation. So then we will have a discussion at the end of the session. So please introduce in the next two presentations.
Great, thank you. So I've got great pleasure in introducing Dr. who is going to talk about the aberrant activation of the MIR10B5P contributing to the pathogenesis of Kawasaki vasculitis.
Thank you for kind introduction, Chairman. And good morning, London, and good afternoon, Korea. It's my great honor to present my recent data in this beautiful conference. And today I'd like to talk about the pathophysiology of Kawasaki vasculitis. Kawasaki disease may be uncommon in Europe, but it's very popular in Far East Asia, including Japan and Korea. The Kawasaki disease, unknown infectious disease. We can diagnose the patient Kawasaki disease when the patient shows high fever more than 5 days, and it shows conjunctivitis and a strawberry-shaped tongue and lymphadenopathy and the swelling of foot or the hand and desquamization of the periphery. But yeah, in the center of this symptom is that there is a vasculitis. The most of the Kawasaki disease spontaneous remission, but the most serious and important complication is coronary aneurysm, and this is the real data from a single patient. After Kawasaki disease, the patient developed severe coronary aneurysm, but after more than 10 years of follow-up, the new aneurysm has developed. So this aneurysm can develop after fully remission the Kawasaki disease. So it takes longer than the normal period of the Kawasaki disease. The main scientists think about this kind of time delay of the vasculitis, the immune cell incorporation in the vessel wall, and the directly regulate the vascular smooth muscle or endothelial cell itself can generate coronary aneurysm. In the later time, the other immune cells incorporate in the same lesion, and it can develop the thrombus or the restenosis. So I think about the kind of time delay. So the kind of longer lasting mechanism should be mediated by the microRNA, by the aberrant activated immune cell. So we collected some human blood in the emergency department. And so if the patient confirmed general febrile illness, we treat it as a control. After the 5 days, more than 5 days, after confirmed as Kawasaki disease, we utilized the sample as a patient group. And we read several microRNA. So when compared to the febrile illness control, the several microRNAs is activated in the patient. So after checking several criteria, we think this kind of the microRNAs as a candidate of the Kawasaki vasculitis. We found several microRNAs activated, but we couldn't conduct the mechanism study in the human. So we generated a murine model of the Kawasaki disease. We generated the lactobacilli cell wall extract model. After injection of SCWE, 4 weeks later, we can see very severe perivalvular vasculitis like a human. So after confirm this successful mouse model, we check the candidate microRNA is truly activated in the murine model altogether. So we confirmed every single candidate microRNA, so one by one. And finally, we confirmed that microRNA 10B5P also activated in the murine Kawasaki model. So we tried to confirm this microRNA is true, the regulator of Kawasaki disease. So we bought some antagonist microRNA inhibitor and inject to the mouse with HW injection. As you can see, that when we treat the microRNA inhibitor, the perivalvular vascularitis is fully suppressed. So we can say the microRNA 10b5p triggers vascularitis, but we further questioned what is the mechanism. So we bought human coronary artery endothelial cell, and we treated the microRNA, and we treated the scrambled RNA as a negative control, and we request single-cell RNA sequencing. And we can get this kind of distribution of the control and the microRNA. We randomly make a cluster into 5 subgroups. And as you can see here, the violet or the scarlet color is abundant in this the negative control. And how can I say, this greenish color, yellow-green color is accumulated in the microRNA treated group. So we further tested the trajectory analysis. The earlier time point shows located here, and the later time point is accumulated here. So after confirming several gene expression pattern, we designated this cluster, the violet cluster, as a proliferative cluster, and the yellow-green color cluster designated into inflammatory cluster. So we can say the proliferative cluster moved to the inflammatory cluster. So after also confirm several the basic experiment, we choose one of the proliferative marker. The MKI67 is a distinct marker of the proliferative cluster, and also pick the several candidate as an inflammatory cluster, such as CXCL8 or CXCL1, and also confirm the expression pattern into the across the cluster. The MKI67 only expressed in the proliferating cluster, and the CXCL8 is highly expressed in the inflammatory cluster. This is also trajectory analysis. After time goes by, the MKI67 is decreased. After fully decrease the expression level of MKI67, the other inflammatory cytokines start to express. So we think that after inhibition of MKI67 expression, at that time the CXCL start expression. So we inhibit the MKI67 in the endothelial cell, and we confirm the expression of CXCL8 is increased. So this is our hypothesis of our model. In the basal state, or the healthy endothelial cell, MKI67 is highly expressed, and from unknown mechanism, it can suppress the expression of this inflammatory cytokine. When the microRNA that treated in the endothelial cell, the MKI67 is decreased, and the certain transcription factor start to express the CXCL8, and the CXCL8 is secreted in the bloodstream, and the CXCL8 can activate the chemotoxic effect of neutrophil, and after the activation of the neutrophil can infiltrate into the blood vessel, and it can regulate the vessel wall and can make aneurysm in the coronary artery. I'd like to thanks to my former postdoc and the current collaborator, Professor Yoon, and also thanks to Sun Young Bak, the student who analyzed the whole dry lab analysis. Thank you for your kind listening. Thank you.
Great, thank you very much. I think we will have questions at the end. So I will introduce our next speaker who's joining us virtually. Vedanta, very nice to see you again. So Vedanta Mehta and I worked together a long time ago. He's now moved on in the world, gone to Oxford, and Vedanta is going to give a talk about the endothelial acts as a mechanical switch for flow-induced physiological or pathophysiological remodeling. Vedanta, welcome, and over to you.
Thank you very much for your kind introduction, Professor Mathur, and I'm delighted to be presenting at GICS once again. It's a lovely conference, and I've really enjoyed presenting here the last few years. Today, I'll be talking about some of my recent work in the field of mechanobiology. So the flow of blood through an artery exerts different kinds of forces on the underlying vessel wall, which include shear stress, blood pressure, and cyclical stretch. Shear stress is the frictional force exerted by blood flow on the underlying endothelial cells, and this force is always parallel to the direction of blood flow. Depending on vessel geometry, shear stress may be either uniform or oscillatory. In straight regions of the vasculature, such as the descending aorta, shear stress is uniform, and endothelial cells in these regions show the classical response of aligning in the direction of blood flow, as well as upregulating atheroprotective genes like eNOS. Whereas in regions of the vasculature where blood vessels either bend or bifurcate, shear stress is disturbed or oscillatory, and endothelial cells in these regions show an upregulation of inflammatory genes, as well as making these regions more susceptible to atherosclerotic plaque deposition. A fundamental question in the area of mechanobiology has been that how do endothelial cells sense and discriminate between these laminar and disturbed oscillatory blood flow patterns? As we see, the entire surface of an endothelial cell is decorated with numerous mechanosensors. These are specialized proteins which endow endothelial cells the unique capability to sense physical forces and convert them into biochemical signals, a process called mechanotransduction. What is important to note here is that all these different mechanosensors do not act independently of each other, but there is a lot of crosstalk and communication between them. And this crosstalk is facilitated by specialized adapter proteins, an example of which is SHIC. An adapter protein is a protein which does not have any catalytic activity of its own, but it is important for signal transduction by forming protein-protein complexes. As we see here, SHIC binds to several different of these mechanosensors, and it helps to integrate signals emerging from them. My lab has been interested in studying the role of SHIC in mechanotransduction for the last several years. In order to do this, one of the first things we did was we generated endothelial cell-specific knockout mice of SHIC using the Cree-Lox technology. So we bred SHIC flox mice with a cadherin 5 Cree mouse to generate SHIC flox cadherin 5 Cree mouse. The cadherin 5 Cree is a specific Cree driver which deletes the gene of interest, in this case SHIC, specifically from the endothelium while keeping it intact in all other cell types. The resultant mouse is termed SHIC IECKO, or SHIC inducible endothelial cell knockout mouse. We began to phenotype this mouse, and we began by looking at the phenotype in the descending aorta. So in the control mice, we took sections of the descending aorta and stained them with phalloidin, which stains the stress fibers, the actin stress fibers of the cells. We then stain with beta-catenin, which stains the junctions between the cells, and finally DAPI, which stains the nuclei. The red arrow here points in the direction of blood flow, and as we see, the endothelial cells are elongated and they beautifully align in the direction of blood flow in control mice. However, when we looked at the SHIC knockout mice, we see that this alignment and elongation in the direction of blood flow was significantly disrupted and reduced, as can also be seen from this quantification here. These data demonstrate that SHIC is required for mechanotransduction responses in regions of laminar blood flow. Next, we asked what happens in regions of disturbed blood flow. In order to address this, we bred a SHIC floxed cadherin 5 Cree mice into an ApoE knockout background to make them hypercholesterolemic and then fed them a high-fat diet for 10 weeks. After this, we harvested the entire length of the aorta and stained it with oil red ore, which is a classical stain used in the laboratory to visualize atherosclerotic plaque. Once again, in the control mice, we see that there is significant plaque deposition in the aortic arch and in the branches emerging from the arch. Whereas in the SHIC knockout mice, this plaque deposition was significantly disrupted and there was virtually no plaque at all, which can also be seen from the quantification on the right. And these data show that SHIC is required for mechanotransduction responses in regions of not only laminar flow, but also in regions of disturbed blood flow. This led us to ask the question that how does SHIC mediate both atheroprone and atheroprotective responses? And in order to address this question, we took a phosphoproteomic approach, which showed us a path to follow that we pursued. And I'll show you some preliminary results of what we obtained. So we cultured endothelial cells and we subjected them to different flow patterns. We subjected them to either laminar flow pattern, subjecting them to the same shear stress, which is seen in the descending aorta, or we subjected them to oscillatory flow and again administering the same shear stress as seen in the inner curvature of the aortic arch. When we subjected them to oscillatory shear, we see that SHIC gets preferentially phosphorylated at two tyrosine residues, 239 and 240. Whereas when we subjected them to laminar shear, we see that SHIC gets phosphorylated at a completely different tyrosine residue, that is tyrosine 317. To see whether these occurrences only happen in an in vitro setting or whether they are even true in vivo, we isolated sections of the aortic arch and the descending aorta and then stained them with these two phospho-SHIC antibodies. Once again, we found that the aortic arch, which is a region of disturbed shear, has preferential phosphorylation of SHIC at tyrosine 239, 240, whereas the descending aorta, which is the region of laminar shear, has preferential phosphorylation of SHIC at tyrosine 317. To further corroborate these findings, we performed a partial carotid ligation model. In this model, 3 of the 4 caudal branches of the left carotid artery are ligated to convert the high and uniform shear stress in the left carotid artery to low and oscillatory shear stress. The unligated right carotid artery serves as the internal control. 3 weeks after the surgery, we took sections of the left and the right carotid artery and stained them with the phospho-SHIC antibodies. And once again, we see that the left carotid artery with disturbed shear has increased levels of phospho-SHIC tyrosine 239, 240, and the right carotid artery has increased amounts of phospho-SHIC tyrosine 317. To summarize the findings so far, laminar shear results in preferential phosphorylation of SHIC at tyrosine 317, and oscillatory shear results in preferential phosphorylation of SHIC at tyrosines 239 and 240. To explore the biological relevance of this and see whether SHIC phosphorylation affects flow-mediated signaling in vitro, we constructed some SHIC mutants. So we made adenoviruses encoding either wild-type SHIC or 2 mutant versions of SHIC in which the tyrosines at 239 and 240 or the tyrosine at 317 was mutated to phenylalanine. When we mutate a tyrosine residue to a phenylalanine residue, we block the phosphorylation event occurring at that particular site. So we overexpressed these constructs in endothelial cells and then subjected them to atheroprone flow for 24 hours. We then examined inflammatory gene expression. The first inflammatory gene we looked at was MCP1 or monocyte chemoattractant protein 1. And we see that there was almost an equivalent upregulation of MCP1 in endothelial cells overexpressing the wild-type SHIC or the Schick tyrosine 317F mutant. Whereas in endothelial cells overexpressing the Schick tyrosine 239-240F mutant, there was a significant decreased upregulation of MCP1. We also looked at two other inflammatory genes, VCAM1 and ICAM1, and once again we see a reduced upregulation of these inflammatory genes in the cells overexpressing Schick tyrosine 239-240F. So to summarize, phosphorylation of Schick at 239-240, these two tyrosine residues, is promoted by disturbed blood flow, and targeting of Schick phosphorylation at this residue blocks pathological responses and may be an option for therapeutic intervention. We are currently doing in vivo experiments where we are overexpressing these mutants in mice and looking at what happens to atherosclerotic plaque development. And I hope to present some of these gene therapy approaches and in vivo data at one of the upcoming GICS meeting. Finally, I'd like to thank my group in Oxford and thank you once again for your attention.
Great, thank you very much, Vedanta, for that excellent presentation. I'll now hand over to Professor An to engage with the panelists, please.
Yeah, okay, so we have three panelists from here and then one panelist from England, so London, Ramasamy. So I think it's Ramasamy. So if you have some questions or comment, please. Can you hear me?
Thank you, Prof. I can hear you well. Hope you can hear me as well. Can you hear me clearly?
Yes, I can hear you.
Perfect, thank you. So Anandarama Ramasamy, I'm an interventional cardiologist from London. Fantastic session. We had three great talks, three different topics, really nice. Two questions for Professor Mehta, if I may. The first one is specifically related to the autologous procedure itself. Just if you can brief us about what the actual procedure involves and what do you tell the patients and what are the risks that you normally will quote to the patients. And secondly, you clearly demonstrated how you've explored patients with poor LV impairment, refractory angina, different subgroups of patients. Thoughts on exploring this on patients with microvascular angina? Clearly, these are patients with very high symptom burden, bad prognosis, but very limited treatment options.
Great, thank you very much for the question. So first on the autologous procedure, the good news is that we tried to design a way of delivering a cell-based therapy that not only had local cell processing, so I mentioned it's the stem cell labs that most hospitals have access to, but also involved intervention techniques that we are all familiar with. So when we first started the procedure, we used a stop flow technique, which is what was published in the Repair AMI study, in which we balloon occlude the target vessel and infuse the cells through the lumen at the time of an over-the-wire catheter. So originally, when this all started, we had a single device that allowed us to do this. We undersized the balloon, or if in the context of patients that have had a stent, we'd inflate the balloon in the stent because we want to minimize any vessel trauma, also decrease the chance of vascular dissection. So in answer to your questions, that's what we would tell our patients that they're undergoing an invasive procedure. We know that the current chances of a complication from any invasive procedure is less than 1%, so they get that figure 2 as standard. And we've not seen any issues to do with infusing cells, leading to microvascular obstruction, no reflow, and the rest of it. Because over-the-wire balloon catheters seem to have been withdrawn universally across the world, we adapted the technique. So we now use a parallel microcatheter and a rapid exchange balloon. So it's a 2-wire technique. The microcatheter goes down, the wire is removed, the second wire goes down, the rapid exchange balloon goes over that. We occlude the vessel proximally with the rapid exchange balloon, and the microcatheter tip is beyond the balloon where we infuse the cells. And obviously, we've tested the integrity of the cells doing that. So essentially, that's the technique, and the consent process is very similar to a regular PCI. And the complication rate to date has been incredibly low. In fact, the only complications I think we came across were in the first studies, Regenerate AMI, when there were a few edge dissections from patients receiving the cell infusion. The second part of your question is about microvascular angina. And I'm pleased to say in the COBRA study that we've just launched here in London, the target population is refractory angina, and we're stratifying inclusion for patients with microvascular disease or INOCA. So those patients will be included. The study is not powered directly around that population of patients, but we will start to get a signal as to whether cell-based therapy has a role to play in that population.
So, Dr. Martha, so I also have some questions or comment to you that, frankly speaking, for the like cell therapy, for the ischemic heart disease or some dilated cardiomyopathy, I think at present situation, it's not optimistic, some pessimistic. But when you think about in the autologous, that means that when we make the bone marrow derived cell, probably it's from the old aging population. So I think it's the source itself is not some like a good condition to make the good cell to treat the patient. So what do you think about that one? And another thing is that still we need some standard protocol, because each laboratory or each center has some different protocol to make different type of cells. Probably we'll get some different results. So still maybe we need some standard protocol. So I understand that in the sophisticated cell type is very needed to the future directions. And then also, so if you think about some intractable, some angina patient treated, so what kind of like underlying therapeutic mechanisms to treat this angina patient? But so I cannot hear you.
Sorry, I didn't hit the mute button. So 3 questions. I think the first question about the logic of using autologous cells in patients who are ill and old. We explored that because, like you, we thought this doesn't make any sense, and looked at a correlation between age and outcome in our patients. And interestingly, we didn't find any correlation at all. So what I meant was that the elderly population of patients in our studies, we would have expected less of a response. And ironically, we saw more of a response. So that really goes to highlight the point I made about the responders, non-responders. And this is where science sort of comes in. We need to get a lot cleverer about it. It was also thought that diabetic patients wouldn't respond because the problem with diabetes and its effect on the glycosylation pathways would mean that these cells would not have a reparative capacity. But again, when we looked in our studies, the diabetic patients actually did just as well as the non-diabetic patients. So I think the answer to your question is that the theoretical reasons as to why autologous cell therapy shouldn't work don't seem to be borne out in the clinical studies, but we do need to get better at identifying the responders, simply because that will mean the studies will then now start to look overwhelmingly positive. But the issue with your second question is, but we do need to standardize how we do it. And I think there's a natural selection process going on, maybe not quite in the Darwinian way, because essentially there are now very few people working in this field in the clinical arena. And therefore there are very few protocols that are out there now. The protocol that we've been using essentially for the last 15 years. And as you saw in my talk, it gave the results that have led us to set up the only compassionate cell therapy unit. So because certainly in the United Kingdom, we seem to be the only people that are doing this, then there is one protocol. So you'd argue it is standardized. But importantly, the next steps are that we are talking to the government and more importantly, the health authorities to basically standardize the treatment throughout the UK and how we did it. So the implication is that if we are to do this with you in Korea, we would again standardize, ideally using the methods that we've used to see if we can apply them to your population of patients too. And like I said, the advantage is it's a relatively straightforward technique, and we have positive data across numerous studies, which makes us a little bit different from what's happened before. So I think we can standardize, and I look forward to collaborating on doing that. And finally, your question was about mechanism in refractory angina patients and angina patients. So from a preclinical experimental stage, several pieces of work demonstrated that angiogenesis is potentially one of the mechanisms. And recently, the Orbiter Coursera study, which used the coronary sinus reducer, demonstrated a difference in perfusion, which again could be because it's triggering angiogenesis, or certainly it's diverting blood flow. So one would like to think that the mechanism involves angiogenesis. The problem we have in human beings is that it's very difficult to show because we don't have any specific non-invasive markers of angiogenesis. So we will be using perfusion scans in the refractory angina study to see if there is a change in perfusion, but that will only be a surrogate way of trying to identify the mechanism. I hope that answers your questions.
Okay, thank you. So we have 3 panelists, so please each.
I'm Yong-Soo Kim from Jeonnam National University Hospital, and I have also a comment to Professor Anthony Mather. Professor Anthony?
Yes, hi.
Yes, so actually I was really impressed by your talk, especially the BAMI study seems to be a kind of a legacy in stem cell therapy field. And now we are having immune cell technologies, which is rapidly advancing and is used in clinical settings so quickly. So I think that it could be more practical to combine the immune cell technologies with the conventional cell therapy technology. And do you have any idea about that?
Yeah, I think there are lots of promising avenues with respect to combination therapies or cellular modification. I think the problem is taking this through to how you would finally deliver it and the costs in so doing. And I think to your point about BAMI, I think what was good about BAMI, because from a science perspective, people would say, oh, that was an abject failure. You never recruited the patients. You never solved the question. Well, we did solve the question, because in recruiting the number of patients, we showed firstly how difficult it is to identify the target population, but more importantly, that actually the premise about how dangerous the condition was had changed due to changes in treatment. So BAMI drew a line, I think, in my mind, to the use of cell-based therapies in treating acute myocardial infarction. And I would argue for most biological therapies, given the complexities in doing it, because the phase 3 clinical trial that you would need to do would have to enroll so many patients, the logistics of such would make it virtually impossible to do, let alone the costs. So I think the future is, when what you say is to be cleverer with respect to modifying the autologous cell, but keep it simple, but also work at identifying the responders so that when we do our studies, we can get a much stronger signal.
Okay, so how about in the Somi Yun? Oh, okay. What's up? So yes, the microphone is not a problem.
Sorry. I have one simple question to Professor Anthony Master. Thank you for your nice and impressive innovation about regeneration stem cell therapy. I think that regenerative IHD project showed only LVEP implement in intramuscular injection, not intracoronary injection. However, according to regenerative DCM project, intracoronary administration of stem cell demonstrated LVEP improvement. I wonder how, why this difference happen in these two different injection methods.
Thank you for your question. I think we need to focus on the objective, and that is the delivery of cells to the target area. And conceptually, the intramyocardial approach would tick the box because we can directly inject the myocardium where we think the cells are going to be most needed. The problem with it is that particularly the current systems, or more to the point, the old system, the NOGA system, there are only a handful of people around the world, probably about 12 centers, that could actually do it. And furthermore, the company Biosense Webster, owned by Johnson & Johnson, withdrew the product from the market. So whilst conceptually intramyocardial injection might be the best way, practically it's not really feasible for the amount of patients that have got heart failure, unless we're suggesting that all interventional cardiologists or all centers have an expert that can actually use intramyocardial injection. And the current range of catheters, and that is an opportunity, I think, are pretty crude. The NOGA system allowed targeting, whereas the current systems do not allow targeting. They're simply injection catheters. And when the intramyocardial systems were withdrawn, we actually looked at the literature to look at the difference between intracoronary and intramyocardial injection. Because even in our most ischemic patients who've got severe coronary artery disease, they clearly have a blood supply, because essentially even so-called dead myocardium is fibrotic myocardium and needs energy to basically, or blood supply, nutrients to survive, otherwise it becomes a hole and the patient dies. So you could argue that actually we're okay with intracoronary injection, because as long as we inject all of the arteries dealing with collaterals and everything else, the cells will get to where they need to get to, because they do have a blood supply anyway. And we looked at the data. There are actually just as many studies using intracoronary injection showing efficacy as there are intramyocardial injection too. So I think from a practical ground, that was a relief. It means that intracoronary can work. And we are pursuing that further in our investigations to be sure that that is not just a spurious finding.
Hello, I'm Somi Yoon from Jeonnam National University, and thank you for a wonderful talk. And I have a question to the third speaker, Dr. Vadenta. It was very interesting that your molecular stock has a different side of phosphorylation and different kind of shear stress. And I was curious what of the basic mechanisms why the phosphorylation sites were different. Is it because of a different kind of receptors that could be activated, or is there any other kinds of kinase that could be enrolled in a different kind of conditions? What do you think about what of that different phosphorylations?
Thank you very much for that excellent question. And that's something that we are currently intensively investigating. We are also very interested in understanding that what is the reason behind these different phosphorylation, because SHIC is largely phosphorylated by Src kinase, but we are trying to explore other kinases at the moment which result in this differential phosphorylation. But what we know at the moment is that, like, as I had mentioned in one of my slides, that SHIC binds to several different mechanosensors. What we know is that following this different phosphorylation, it binds to different kinds of mechanosensors. So whereas in response to laminar flow, it largely binds to integrins to transduce atheroprotective signaling. In response to oscillatory shear, disturbed shear, it binds to mechanosensors like ALK5, which is TGF-beta receptor 1, to analyze signaling along a completely different atheroprone pathway. So we know it forms different complexes in response to different shear, but which kinases are responsible for the differential phosphorylation is something we hope to have an answer of in the next few months.
Okay, thank you. So is there any questions or comment from the audience? No? So I think it's the Dr. Martha. I hope you will make some closing remark.
Again, thank you ever so much for inviting us. We really enjoy the close collaboration between London and Korea. Another great session. Thank you to all the speakers. Very diverse, lots of different areas of interest and things that are going on, and an interesting sort of insight into translation, the challenges in translation, and essentially what's up and coming in the future with the identification of molecular pathways that hopefully one day will have a clinical input. So on that note, again, I wish everyone a very happy afternoon, evening in Korea. I thank you to our colleagues in London for all their support and their great talks, and Oxford, that is. And again, thank you to the organizers for inviting us. We really enjoy being part of this. Thank you.
Okay, thank you. So see you next time. So thank you, everyone.
Bye.
Now it's time to wrap up the second day of 2024 GICS. We very much appreciate your attendance and discussion. Hope we'll get the chance to see you all again. Thank you.